So I think, Michalis, shall we start slowly? I mean, to do the introduction and everything, yes?
I think we're enough now. We're good to start. Yes, we have a lot of things to say. So yes, I think we should start now. It's already 3 minutes, 3 minutes to past 10. So yeah.
Okay. So, dear colleagues, ladies and gentlemen, on behalf of the Hellenic Society of Breast Surgeons and the organizing committee, would like to welcome you to this webinar. We have been doing this webinar for some years now, but this year we tried to get it outside of the borders by joining Breastix 24 and get more international. And hopefully next year will be bigger and bigger all the time. So the concept behind this virtual MDT is to discuss borderline cases in a very interactive way. This year we have more than 50 questions placed in key points between the cases. So every single one of us will be able to vote at specific parts of the case. And then we'll get expert panelists to discuss each and every other question, the pros and cons against each option, which is better and which is worse. This year we changed something in the second part. We made it more thematic, and we have for each molecular subtype, we have short cases with short questions focusing on these key points for each different molecular subtype. Hopefully, all this interactive procedure will bring us together, will make us exchange opinions, compare different guidelines, and of course, make us think outside of the box. It took a lot of effort to get here and a lot of preparation. I would like to thank everybody who contributed to this. And hopefully you're going to enjoy it as much as we hope you will, and it will meet your expectations. So I would like to ask Michalis now to introduce the panelists and say some comments.
Thank you, Sophocles. I will try to keep it very short, but I still have to thank a few people. First of all, thank all the attendees for making time in Saturday morning and afternoon. I do, and we all hope that you will find this enjoyable and educational at the same time. So welcome. Second, I would like to thank a special thank you to all the participants, all the presenters of the cases, and the members of the panel. Because you know it is challenging to construct a case, take the photos, write the text, search the literature, exchange a lot of emails with us to make sure that everything is as required. And I'm sure that this time they dedicated to this was taken out from their personal time. So a very warm thank you to all the presenters and all the panelists who are participating today. Without them, this webinar wouldn't have happened. So thank you very much. The third person I would like to thank is our sponsors. You know, nothing goes around without money. So let me just mention them. So Gene Analysis, BARD, GeneCore, and MedTech are sponsoring today's webinar. And this gesture and this interest of theirs to this educational activity reflects back to them. So thank you again for that. Sophocles said about our collaboration with Breastix 24. This webinar has been going on for years now in Greece, but this year, because of the success, I dare to say, in the last years, we are crossing the borders. We're inviting international colleagues. It's always nice to see how they react to the challenges we face here every day, and what guidelines they have and how they manage things in these borderline cases. It will be constructive for us, and I hope for them as well. So to make this webinar international, we got help from the team of Breastix 24 hours, and special thanks to Dr. Bahadir Güloglu for giving us this opportunity. So thank you, Bahadir. He will join in later, I think. Finally, just to mention Eleni Halividou and Michalis Andreadis. These are the technical and IT team taking care of this. We have been working with them for years, and I'm sure that they will succeed in their mission today. Before presenting the members of the panel of part one, I would like to invite Vasilis Venizelos to the microphone. Vasilis is the president and chairman of the Hellenic Society of Breast Surgeons, and I think, Vasilis, you want to say hi.
Good morning. Thank you, Michalis. Good morning to everybody. I don't want to spend your time, but I would like to thank everybody for their participation. I would like to thank the international speakers, the great presenters, the participants, especially thanks to Bahadir Yulioglu. But above all, I would like to thank Sophocles Lanidis and Michalis Kodos. They've put a lot of effort to make this webinar reality. It's not an easy work to organize, and these two guys, they've spent a lot of time to organize this meeting. Thank you very much again, Sophocles and Michalis, and the microphone to you, Sophocles.
I think Michalis should introduce the panelists. Yeah.
So starting part one, let me present the panelists first. So the panelists are the colleagues who are going to comment and ask questions on the presented cases. So the members of the panel of part one are Elias Koteas, is from Soteria Hospital, a medical oncologist. Hello, Elias.
Hello, good day to you. I would like also to congratulate Sophocles and you, Michalis, for this excellent effort. Okay.
Thank you, Elias. Dr. Dimopoulos, who from Metropolitan Hospital here in Athens. He's a radiologist, radiology oncologist. Hello, Thanos.
Hello, good morning. I also would like to thank you for the invitation and also congratulate you for this nice effort.
Then is our old friend and colleague from the UK, Yazan Mazanat. I'm sure that everybody knows Yazan from Aberdeen, the Royal Infirmary in Aberdeen. Hi, Yazan.
Hi, Michalis, and many thanks for the invite. It's a pleasure to see you all.
What part of the world are you now in?
No, I'm at home. This is the conservatory.
So at home, fine, good. Good. Then I have the pleasure of introducing Thodoris Kondoulis from Thessaloniki here in Greece. Is Thodoris here?
Something occurred to him. It's going to be within the next 10 minutes with us, he said.
Okay, he will join soon. And then our old friend from Guy's Hospital in London, UK, Asko Tari. I think he will be joining in the next minutes. Giuseppe Catanuto from Sicily, Italy. Hi, Giuseppe, welcome. Panagiotis Hortis from the UK. Hi, Panagiotis. He will be presenting the first case.
Good morning, everyone, and thank you very much for the invitation and the great organization of this webinar.
Thank you. Konstantinos Zachariudakis from the UK again. Hi, Konstantinos.
Hi, good morning, everyone. Thanks for the
Welcome
invitation
aboard.
and thanks for all the effort for the webinar.
And last but not least, Maria Luisa Gaspari from Lugano, Switzerland. Hello, Maria Luisa, welcome.
Hi, everybody. Thank you. Congratulations, as previously said by my colleague.
Very nice to have you here. Sophocles, you are taking over.
I would like to thank Andreas Karagatsanis, who's with us in the first part also. He was assigned in the second part, but Andreas loves debates and loves discussing cases. So he's here with us from part one, and that's a great pleasure.
Thanks a lot. I'm curious, so
I know you are. So I'm going to talk a little bit about the technicalities now, how it's going to work. Each presenter is going to start presenting the case, and it's going to be a normal flow of the case as it happened. So on specific key points, the presenter is going to stop and give us a multiple choice question. It's going to be 1, 3, 2, or 5 answers. So the presenter will ask those questions, and then the presenter will give us time, 10 or 15 seconds, to vote. So a poll box will appear on your screen, and you're able to move this box by clicking on it and dragging right or left in the screen, so you will be able to see the questions and the poll box in the same time. So you can vote by pressing the equivalent key, 1, 2, 3, 4, or 5. And as soon as you finish, the presenter will just ask for the voting results, and they will appear on your screen. So next to the question, you'll have a box with all the voting, all the answers, the ones you voted and the ones that everybody else voted. So the panelists at that point, me and Michalis will give the stage to one of the panelists, and they will discuss the answers of the voting. And after we finish with that, then we can move on to the next slide, etc. and etc. It's not a very difficult process. You'll find out in a way that is quite easy for everybody to follow. So be sharp, be there, be prepared, and I think we're ready to start. So our first speaker for today, it's gonna be a very good friend of mine, Panagiotis Chortis. He's just now in the United Kingdom. He's a senior clinical fellow, and he will present a triple negative breast cancer case with axillary lymphadenopathy and complication from neoadjuvant chemotherapy. Panagiotis, the stage is yours.
Good morning, everyone, again. Let me share the screen first. Can you all see it?
Yes, where to go.
Okay, great. Right, good morning again. Before I begin my presentation, I would like to thank the organizing committee for giving me the opportunity to be among the presenters of this very important webinar that we are all going to watch today. Especially many thanks to my teacher and my mentor in Athens, Mr. Lanitis, Mr. Kondos, and Mr. Venizelos for this opportunity. So I will begin the first section of this webinar by presenting my case, which is regarding a patient with a triple negative breast cancer and concomitant axillary lymphadenopathy who also suffered from some complications during her neoadjuvant treatment. So the case that I'm going to present is regarding a 41-year-old patient who was premenopausal on presentation to the department. She presented to the breast clinic with a palpable lesion in her right breast, which she has had since mid-2021, so essentially since the summer of 2021. The patient had never had any breast screening in the past. She was quite a difficult patient, quite a complex one, not been very cooperative, and she wasn't very keen to engage with the surgical team. She was otherwise fit and well, on no regular medications, and she had a performance status of 0. Regarding family history, her father had lung cancer. However, the patient did not have any family history of breast or ovarian cancer. Now, clinically, the breast size for this patient was a big cup, and on examination, there was a palpable mass in the upper outer quadrant of the right breast, roughly at 9 to 10 o'clock position, which was 3 by 3 centimeters in size and was quite hard and firm on palpation. So essentially, it was a P5 lesion clinically. There were no skin changes to the breasts, and there wasn't any nipple discharge either. And on examination of the axilla, there was a palpable abnormal lymph node in the right axilla measuring 2 centimeters in size. So gathering the information that we've got thus far, the clinical classification, the clinical staging of this lesion would be a T2N1M0. Proceeding with the triple assessments, we performed the mammogram and an ultrasound scan, which both revealed the presence of a suspicious lesion at 9 to 10 o'clock position of the right breast, which was heterogeneous with irregular borders and internal vascularity, measuring 3.5 by 1.7 centimeters in size. And that was given an M5 and a U5 respectively by our radiologists. Right adjacent to this lesion, there was an additional second focus measuring 9.5 millimeters, and the distance between the two aforementioned lesions was 10.29 millimeters, so roughly about 1.3 centimeters. Checking the right axilla with a probe, there were 4 suspicious abnormal-looking lymph nodes in the right axilla, the largest of them being 2.4 centimeters in maximum diameter. The second one was 2.3 centimeters, and the smallest 2 suspicious lymph nodes were 8 millimeters in size each. Checking the left breast now, there were various benign-looking small nodules throughout the breast, the most noteworthy of them being at 8 o'clock position, which was a 9mm nodule, hypoechoic and lobulated, with sonographic features consistent with a fibroadenoma. So that was graded as a U2. Now, on the right side of the screen, you can see the suspicious lesion. You can also see the irregular borders, the vertical orientation, the internal vascularity. So all these are quite sinister, quite suspicious features. On the right-hand side, you can see the second adjacent focus, 9.5 millimeters in size. And as we have said, the distance between these two areas was 1.3 centimeters. Now, on the bottom two images, you can also see the largest axillary lymph node from the right axilla, which was 2.4 centimeters in maximum diameter. Subsequently, we performed the breast MRI for our patient, which confirmed that at 9 o'clock position of the right breast, we have a suspicious lesion, 3.5 centimeters in size, which was lobulated with regular borders, displaying a type 3 hemodynamic curve. So again, the lesion was given an MR5 by the radiologists. The lesion itself was situated a few millimeters distant to the chest wall without any direct infiltration to the pectoralis major muscle. And indeed, by checking the report from the MRI scan, there was a visible, although thin, layer of fatty tissue between the lesion and the chest. In addition to that, there were multiple other areas in both breasts measuring up to 5 millimeters with gradual contrast enhancement. All these areas were consistent with fibrocystic benign changes, and they all displayed a type 1 hemodynamic curve in contrast to the initial suspicious lesion on the right side. Checking the right axilla, there was one enlarged lymph node measuring 1.5 centimeters in size. And on the screen, you can all clearly see the lesion in question, which is at 9 o'clock position of the right breast in close proximity to the chest wall. So let's summarize the information that we've got so far. We've got a patient presenting to clinic with a palpable lump in the right breast. On examination, she's got a 3 by 3 centimeter firm mass in the upper outer quadrant of the right breast and the palpable lymph nodes on the right-hand side, which is 2 centimeters. We perform our imaging. We begin with a mammogram that reveals a spiculated lesion, 3.5 centimeters in size in the upper outer quadrant of the right breast, and that is given an M5. The patient has an ultrasound next, which again shows at 9 to 10 o'clock position of the right breast, the suspicious lesion, 3.5 by 1.7 centimeters in size. Right adjacent to that, a second focus, 9.5 millimeters, the distance between them 1.3 centimeters. And on top of that, we've got 4 to 5 suspicious axillary lymph nodes, their sizes ranging between 24 and 8 millimeters. And in the end, we have a breast MRI, which confirms the lesion in question, which is a 3.5 centimeter lesion at 9 o'clock position with a type 3 hemodynamic curve and one abnormal axillary lymph node, 1.5 centimeters in size. So far, our clinical staging is a T2N1 with 4 suspicious lymph nodes on imaging. And now it's time to make the presentation a bit more interesting to everyone, a bit more interactive, because it's time for the audience to begin voting. And the first question that I would like to address to the audience is that in addition to the core needle biopsy of the breast lesion, that I believe we all unanimously agree that it needs to take place at this point, what else would you advise? Would you proceed with a fine needle aspiration from one of the suspicious lymph nodes, with core needle biopsy from one of the lymph nodes, fine needle aspiration from all the 4 suspicious lymph nodes, core needle biopsy from the biggest axillary lymph node, and simultaneously fine needle aspiration from the remaining 3 suspicious nodes? Or you feel that since the lymph nodes in this patient are grossly involved in imaging, there isn't any need to obtain any further information either by cytology or biopsy for this patient, as she wouldn't be a candidate anyway for a targeted axillary dissection and a sentinel lymph node biopsy. So it's time to begin voting now. You can see the table on screen. You will have 15 seconds, as Mr. Hellenic said. So please cast your votes now.
Let me interrupt. I can see question 6. It is question 1, and it has five.
Yeah, it's the wrong question. It's the wrong question. Yeah. Thank you, Mr.
Can we, excuse me for a second, can we please have a 5 option poll box?
Yeah.
And if it's
Mr.
possible,
Andreadis.
Mr. Andreadis, and if it's possible to get the poll box as soon as we read the questions, and then we'll get the poll box. Can we get now a 5 option? Okay, there it is. Okay, let's start now. We have 15 seconds to decide and vote whichever option we think is the more appropriate in our opinion. Okay, let's start now. I think there was plenty of time. Let's see the results. So as I said, you can click and move the box around so you will be able to see both the questions and the answers. And I would like Giuseppe. Giuseppe, would you like to comment on this?
Sorry, I didn't have the chance to vote.
Okay.
Can I vote again?
No, in the next one, I guess. Let's do it in the next one.
Okay.
Okay, most people voted that they would do a core needle biopsy from one lymph node. So what is your opinion about the answers of the audience, and what is your opinion about how to deal with 4 lymph nodes in the axilla?
I will definitely go for a core biopsy of the first lymph node, and obviously, potentially, I would keep a clip inside, which is not mentioned here. And obviously, I will proceed and then see with the treatment how he's going to respond. We don't do F-pi needle aspiration for assessment on lymph nodes. We want more information about disease in the lymph nodes. And I wouldn't care about the other suspicious lymph nodes in the axilla because I'm going to check the axilla with sentinel node biopsy after treatment.
Okay. And I would like to ask Andreas. Andreas, what is your opinion about having 4 lymph nodes positive? Is it a candidate for TAT, these patients with 4 lymph nodes?
Okay,
positive?
that's a good one. So we have 2 things here that we need to discuss. The first one is that you have a patient that's clinically node positive at presentation, okay, and the presence of multiple lymph nodes. We know that usually in the presence of multiple lymph nodes in the ultrasound, the pathology stage of the axilla, if we were to operate up front, would upstage. So if we are talking about radiologically something that is towards the N2 area with the 4 nodes, for example, that would have higher probability of being a pathologically node 2. So we would formally need staging here. On the other hand, we know that there is the Lucerne toolbox that is suggesting that we should consider N1s for de-escalation. On the other hand, the data suggests that once you've got complete pathologic response, these things do not matter that much. I am aware of most people being skeptical in the N2 axilla to de-escalate afterwards. But on the other hand, studies that suggest that you have a good radiological mapping of the axilla before and after can give you more freedom. So if you ask what I would have done here, this would be a candidate for PET staging at my institution, and she would be followed with PET after the second or third and last cycle. And if we had complete radiologic response, we would discuss that with the patient and we proceed for targeted axillary dissection.
Thank you very much. Anybody else from the panel wants to comment something about this question, or shall we move on to the next one? I think we should move on.
Question.
Yazan, I think, has
Yazan.
raised it up.
I just wanted to say, where I work, we're part of the Hellenic study. So there has been lots of discussion about clinically N1 and N2. And in the past, when we started recruiting patients, we were very uncomfortable to include radiologically N2, but clinically N1 patients like this one. But now it's very clear from the criteria of the studies that as long as they're not big matted nodes, as long as it's not clinically N2 node, if there is a complete response, then you can do that. I voted for the clinical node for the biopsy from one node, but what we have in our clinic is we have immediate cytology. So when the patient comes, they'll have a biopsy from the breast, they'll have cytology from the axilla. The cytology is read on the spot. And if it's not confirming malignant cells, then we'll go for the clinical node biopsy. And we'll also, of course, put a clip in that. So different ways of doing the same thing, I think, between different parts of the world.
Thank you very much. Panayotis, can you click on your slide in order to proceed with the next one?
Yes, of course.
Okay, move on.
Okay, thank you very much. So what we did next was to take a core biopsy from the lesion in the right breast, and at the same time we took a core biopsy from the biggest axillary lymph node from the right axilla. And both the specimens revealed the presence of a grade 3 invasive ductal carcinoma, which was ER negative, PR negative, and HER2 negative, so essentially a triple negative breast cancer with a very high proliferative index. And in this case, Ki67 was 80 to 85%. Certain other immunohistochemical features that are important in this case is the presence of a positive CK5 and 6, which would imply a more basal-like molecular phenotype for the cancer, and a positive CK8 and 18. Following this, we performed staging for the primary lesion, which was negative for any secondary deposits. And of note is the fact that we also performed testing for any potential pathogenic mutations of the BRCA1 and 2 genes, which was also negative. So the next most appropriate step in the management of this patient, in your opinion, would be to begin with upfront surgery, to start with neoadjuvant chemotherapy without placing any clips in the breast or the axilla, to insert a clip inside the breast lesion and then take the patient to neoadjuvant chemotherapy, to put a clip inside both the breast lesion and the biggest axillary lymph node and then take the patient for neoadjuvant treatment, or insert a clip in the breast lesion and all the aforementioned suspicious lymph nodes and then proceed with neoadjuvant chemotherapy. So again, if we can see the table on the screen, please, for the voting.
So we can start voting now for
15 seconds again.
Giuseppe,
Yes.
please, you can vote now. You have time.
Okay.
Remember, you have to press submit, vote and submit, vote, submit.
Okay, can we see the
Okay.
answers, the voting poll? Okay. Maria Luisa, what is your opinion about this?
Thank you for asking me. Well, what can I say? I agree with the majority of respondents. In my opinion, it makes sense to put a clip in breast lesion first, but also in the biggest suspicious node. Despite the ongoing success trial, which is currently evaluating the node inferiority of the target axillary dissection to axillary lymphadenectomy, include all patients with most of the suspicious lymph node marked, I think that it's a risk to mark more than one lymph node. Since if our aim is to obtain a de-escalation of surgery, the risk is to affect patients to high morbidity. We can consider that with a median number of marked lymph nodes of 2, the median number of removed lymph nodes is between 1 and 5. And if we mark a median number of lymph nodes of 4, the median number of removed is between 2 and 10. I mean, we are in a borderline with the definition of axillary lymphadenectomy. So probably we miss the advantage of a de-escalation of surgery. So I think that it's reliable to mark only the most suspicious node and undergo neoadjuvant chemotherapy.
Thank you very much. Giuseppe raised the hand, so I think stage is yours.
Yes, and thank you very much. Obviously, I've staged this patient as an N1, and I performed the biopsy only on one single lymph node, and I totally agree. This is a triple negative breast cancer, and she's likely to get a response also in the axilla, and I would make all the attempts to de-escalate on the axilla. And that's why I'm going to clip either the breast and the lymph nodes.
Is anybody going to clip
And sorry,
the lymph nodes?
Sorry. Obviously, after I would stage also with a CT scan or maybe a PET scan before, after clipping the lymph node.
Okay. A final question for the panelists: does anybody want to clip more than one lymph node at any case? Are there any cases that you would like to clip more than one lymph node? Is anybody favored of that? Michalis raised the hand, so Michalis?
I'm trying to raise my hand here. I don't think I would clip more than one nodes, but I would think of clipping the two foci in the breast, because you have an ultrasound scan saying that you have two foci close to each other, one big one, 3 or so centimeters, and then another one in about 1.8 centimeters apart. So I'm not sure that if this patient gets neoadjuvant chemotherapy, which is the right thing to do, it would be very easy to find the area where the small tumor used to be. So I'm just putting it up for discussion. I would very seriously think of clipping both of the tumors in the breast. And the second question I would like to ask one of the medical oncologists, actually, if Elias is listening, is whether the CK46 positive result and CK818 positive result makes any difference to the systemic therapy treatment.
No, Michalis, this is going to make no difference. I think we all agree here that this woman should be treated with, according to the Keynote 522 schema. I think it's quite clear here.
Okay.
I think
So
Konstantinos Zaharidakis has raised the hand. So what's your opinion about the questions of Michalis? Would you clip the second lesion or would you clip a second node?
No, I wanted to comment on clipping a second node. So our practice, normally we just clip one node, the most suspicious node, the one that we've biopsied. There are a few exceptions, like in cases where there is a suspicious node, let's say low in the axilla, and there's a second node in a very different position, far away, that's proven positive. And that would be the only scenario where I would clip two nodes. But if it's in a very different position, like high up in the axilla, I would consider clipping a second node. Otherwise, like in the majority of cases, only one node.
And what about the lesion, the breast lesion? Would you mark the little tiny foci, which is 1 centimeter away?
I wouldn't. I wouldn't, because it depends. If it's only 1 centimeter away, I would not put a second clip there. But if there is a distance, in any case, you would have to remove both, regardless, like the whole area now.
Yeah.
Regardless of the response.
Andreas?
With regards to the axilla, exactly what Kostas said. So we have clipped a second node only in the cases of non-single lymphadenopathy. So you've got two that are not adjacent and that they may anatomically belong to a different group. And if both are proven pathologic, in that case, we would like to have pathologic confirmation or cytologic confirmation. And in that case, if it was not a given that it would be removed, we would like to do that. But this is an exception to the rule. With regards to the outcomes of the clipping strategy of the breast lesion, my understanding from that MRI slice is that what seems to be a second lesion on the ultrasound, like a big and a smaller satellite-like one, they were one mass-forming lesion on the MRI. So I think that I would just go for that and put a clip in the middle of that lesion corresponding to the bigger tumor, so to say. So I would not go for two. I would just be conscious of considering the patient as somebody who has a larger tumor than what the ultrasound suggests I would have done with the MRI measurements.
Thank you very much. Vasilis?
Well, as far as axillary lymphadenopathy is concerned, I totally agree that one clip is enough. A very good question from Michalis. I will try either to do a core biopsy for the small lesions, or if it's not possible, I will clip it as well, because the distance between the two lesions is about 1 centimeter. And probably we will miss this area. Therefore, I will put two clips, one in the big lesion and one in the small lesion.
Okay, thank you very much. So looking forward to what happened after that, Panagiotis.
Okay, so moving on, thank you. Here we can see the ultrasound images prior to commencement of the neoadjuvant treatment. And on the left-hand side of the screen, we can see the largest axillary lymph node on the right side, in which a metallic marker was placed. And on the right side of the screen, we can see the metallic marker placed inside the breast lesion. And by checking the bottom two pictures, we can clearly see two metallic markers, one of them in the axillary lymph node and one inside the breast lesion. So following this, we discussed the case in our multidisciplinary team meeting, and a decision was made to proceed with neoadjuvant treatment first, which consisted of anthracyclines, taxanes, and pembrolizumab for immunotherapy. Unfortunately, the patient had some rare but severe complications from administration of the immunotherapy of the pembrolizumab. In particular, she developed hypophysitis, which is an inflammatory condition of the pituitary gland, and myocarditis. Due to the presence of these complications, the patient was not very cooperative. As I stated early on during the presentation, she wasn't the easiest patient. She was a bit reluctant to engage with the surgical team. So although the neoadjuvant treatment was eventually completed, the operation itself was delayed for a period of 3 months due to the presence of these complications. I would also like to mention that the patient received a course of steroids as per the guidelines for management of these rare complications. So now we can see the ultrasound images after completion of the neoadjuvant treatment. And indeed, if we look a bit closer, we can see that there is a normal appearing lymph node in the right axilla with a marker in its center. We cannot see any thickened cortex. We cannot see any enlarged lymph nodes surrounding this area. And in the bottom two pictures, we can see that we've got a visible marker inside the breast parenchyma without any residual suspicious lesions in the upper outer quadrant of the right breast. So according to these images, we've got complete clinical and imaging response. And this is further confirmed by a mammogram that we performed after completion of the neoadjuvant treatment, in which we cannot see any spiculate masses. We cannot see any distortions of architecture. The only thing that is clearly visible on the mammogram is the metallic marker, which is present in the upper outer quadrant of the right breast. And this is evident both on the CC and the MLO views. So again, this implies complete clinical and imaging response of the tumor. So taking that on board, which one would you feel that is the most appropriate management step from this point forward for this patient? Would you proceed with a mastectomy with axillary node clearance, mastectomy with targeted axillary dissection and sentinel lymph node biopsy, wide local excision including the initial area of the original tumor with axillary node clearance, wide local excision including the initial area of the original tumor with a targeted axillary dissection and sentinel lymph node biopsy, wide local excision including just the clip and its surrounding area with axillary node clearance, or wide local excision including only the clip and its surrounding area with a targeted axillary dissection and sentinel lymph node biopsy. So we're very interested to see what your opinion is on this question. So can we, yeah, we've got the template. So if you could please cast your votes now, you've got 15 seconds again to do that.
So I remind you, just you click on the option you like and then you press submit. Okay. And
Can we see the results, please?
around.
Thank you.
Okay, so who start first? I think we should get Yazan. Oh, Michalis. Okay, Michalis.
Sorry, Yazan, let's give the mic to Yazan, I think. Until Yazan joins, I just want to highlight the fact that the multiple positive notes at the beginning do not discourage people for trusting chemotherapy, especially in these chemosensitive tumors, and doing TAD. And Maria Luisa Gaspari published a paper, we did it together, Maria Luisa, about the beliefs and the trends regarding TAD or axillary procedures after neoadjuvant chemotherapy. It's very interesting that N2 does not discourage us from target axillary dissection.
It's quite interesting, actually. I didn't expect that people would be so adventurous. So, Giuseppe, what do you think about it? 60% would do.
Were suspicious, were not positive lymph nodes, were just suspicious.
Yes,
Okay?
indeed.
Yeah.
I think we need to, you need to see, what do you believe axillary surgery is? Is it a staging operation or is it treatment operation? And I think axillary surgery is just staging operation with local control. And if there is complete response on imaging, you're going to take those areas out. So you take those TADs or you do a sentinel biopsy, take 3 or 4 or 5 nodes or whatever. And if there is still residual disease, you will treat. If there is no residual disease, you will not treat, because why should you assume that the biggest node had just completely resolved and the small ones still have cancer cells in them? That does not make sense. So if the biggest nodes have resolved and responded completely, then there should be nothing in the other nodes, theoretically. And also, you need to remember that we're doing a conservation for this patient, and you just need to remove the clip. There's no point in removing the whole footprint of the initial tumor. You just need to remove the clip and see how much is left there, because more than 50% you'll find no further disease. This is a basal phenotype from the cytokeratin positivity. So there's a basal phenotype tumor, and it's likely to respond really well. And remember, even if you have residual disease in the axilla, it is very low residual, very low volume residual disease. That's why you cannot see it on imaging. And many of the times, your radiotherapy will sort it out.
Konstantinos. Hagidakis.
Yeah. Sorry. So what I wanted to say is the question I think we need to answer is, do we believe TAD in this scenario has enough, the false negative rate of TAD is low enough to accept it? So I think this is the question. So I personally believe it has, that the false negative rate would be really low. So performing target axillary dissection in a patient that has 4 or 5 nodes initially, which is still in one disease clinically. There's a difference between clinical stage for the axilla and pathological stage. So 4 nodes, it's still in one radiologically, clinically. So if you have a complete response, I feel that target axillary dissection has a low enough false negative rate to accept it. But we still are waiting for more evidence, to confirm that from the ATNEC trial, for example.
I think I saw a hand raised before. Okay, that's it, Giuseppe. Yes.
Yes, once again, this patient is going to have, I think, the most sophisticated treatment, which is immunotherapy. And she will have immunotherapy also in the postoperative setting. And also, we can decide to give her regional nodal radiation, possibly if she still have 1 positive node. Obviously, at this stage, we don't know the results of the TAD.
So, and another thing that is slightly unresolved is how much to remove. So to remove the clip and the area around, or the initial area of the tumor. Mr. Dimopoulos, what would you like us to do? Would you like us to remove the clip only, or would you like us to remove the initial area of the tumor?
I would like to remove the initial area of the tumor so that I'm sure that there is no microscopic disease left behind. And about the axilla, because this patient will receive regional nodal radiation, and there is the belief that we are able to sterilize the axilla with radiation, but we do not have prospective data yet, as you said, the ATNEC trial and the rest. So, but maybe in the future it will be the approach to use only TAD. At the moment, I think we do not have enough data for that.
Vangelis, Mr. Magoudakis, welcome. Good morning.
Morning, everybody. I totally agree with my friend Dimopoulos. We want to be sure that we have complete response. So if we left disease behind, that's going to have wrong information for the decision making for further treatment.
Can I say something?
Yes. Yes.
I'm always controversial, I think, but I don't agree with that. I think we just need to remove the clip, as long as the clip is the correct place. Even, and I think, if I'm not mistaken, please correct me, Andreas and Giuseppe and the others. Even the St. Gallen a few years ago, they said even if you have small foci, as long as you remove the main tumor and there's complete response in the main tumor, you don't need even to worry about the rest. Because why should you assume that the big area that had the bigger disease has completely responded and the smaller areas did not respond, as long as they're the same pathology? So if you're sure that they're the same pathology, you just need to remove the clip, because if it's going to respond, the whole area will respond.
So let's,
Pathological
Panagiotis,
disease.
what did you do here? So can we see what was
Of
the outcome
course.
of this?
Of course, yeah. So moving on in the presentation, what we eventually did was to perform a right breast wire-guided wide local excision, including only the clip and its surrounding tissue. And regarding management of the axilla, we performed targeted axillary dissection with a sentinel lymph node biopsy. The size of the white local excision specimen was 5.5 by 4 by 2 centimeters, including the metallic marker. And from the final pathology report, we found that there was complete pathologic response of the tumor from the breast and the axilla. So there was no residual invasive component, no residual in situ component, no DCIS in either the breast or the axillary lymph nodes. Now, regarding the lymph nodes in the right axilla, we excised 3 of them during the targeted axillary dissection, and all 3 were negative for malignant infiltration. On the right-hand side, we can see the surgical specimen with a metallic marker in its center, right adjacent to the guide wire that was used for localization intraoperatively. And I would also like to remind you the biology of the original tumor, which was a triple negative grade 3 breast cancer with a very high proliferative index, so quite aggressive and sinister characteristics. Now, taking into consideration the state of the right axillary lymph nodes prior to commencement of the neoadjuvant treatment. And I would like to remind you that we had at least 4 suspicious nodes on imaging. And the results from the targeted axillary dissection, in which 3 lymph nodes were excised, all 3 of them being negative for cancer. Would you feel that the patient needs additional axillary lymph node clearance for completion, that the patient would need radiotherapy to the axilla, supraclavicular and infraclavicular areas? Or you feel that the management that has been done for the axilla so far would suffice and there isn't any need to perform anything additional for this axilla apart from just observation? So I'm looking forward to seeing your responses again. If we can see the table, please, on the screen with the answers. Thank you. So you've got 15 seconds again to cast your votes. Please start voting now.
Try to be honest when you vote. What would you really do? Not what the guidelines say, but there are no guidelines for this anyway.
Right. Thank you. So can we have the results, please?
Would expect a 30%. Okay, so 9% think that it's not enough. We took 3 out of the 4 suspicious out. 66% believes that radiotherapy it's going to be okay to cover the axilla, and 25% thinks that we're fine and we don't need to do anything else, which is quite adventurous. And I would like, I think, Mr. Maragoudakis, because it's mainly radiological question, this one, to tell us what he thinks about it.
Well, I'm not a panelist yet, so perhaps the question has to be answered by Dr. Dimopoulos.
Okay, sorry, because it was a raised hand. That's why I gave you the word, because
I have to take it out. Okay, sorry about that.
Okay, Mr. Dimopoulos then.
Okay, I think I already stressed this issue. I think, yeah, at the moment we do not have enough data, but this is more or less a surgical question, because there is one answer missing, and the answer is the patient should undergo axillary lymph node dissection and afterwards should receive radiotherapy to the supra-infraclavicular areas. So this would be an additional answer, and most probably I would choose this answer. So I do not think that somebody here can support that plus radiation is enough in this patient by using any prospective data.
Maria Luisa, what do you think about it?
Thank you. I think that sometimes radiotherapy and axillary dissection can be interchangeable, as we saw in other settings, such as not in neoadjuvant chemotherapy. I think that if this patient underwent axillary lymphadenectomy, might be useful in order to give or not the indication to radiation therapy. This is my first comment. And secondly, I think that post-operative radiation therapy, anyway, according with most of the guidelines, relying on 3 neoadjuvant chemotherapy disease stage. So probably I trust in addition anyway of radiation therapy in this case.
Thodori, Mr. Gondoulis, would you like to comment on that? Would you do nothing on this axilla? Just rely on TAD, and 25% voted that they wouldn't do anything and just observe without radiotherapy and without clearance. What's your opinion about that?
Sophocles, I would rely on TAD because first of all, we have the magic number of 4 lymph nodes, which is, we know that from the guidelines that we say we shouldn't do TAD if we have 4 lymph nodes or more. But we know that this cutoff number remains unknown because the relationship between the number of ultrasound abnormal lymph nodes prior to neoadjuvant chemotherapy and nodal resolution is unclear. For me, I don't do TAD when we have 4 lymph nodes because it is logistically and clinically cumbersome to do, but it is unclear. If we agree to do TAD on this case, we should accept the results. And I wouldn't do axillary node clearance in that case. I would rely on TAD.
I want somebody to comment on doing nothing. Andreas, are you with us?
Yes, I am. But
I mean, we need to answer to these 25% of people who voted nothing.
Yeah,
if we have any evidence about that.
I would not feel very confident in telling people that there is adequate evidence to do nothing. So, I mean, until now, we know and practice in the sense that with regards to decisions on postoperative radiotherapy, we heavily based our assessments to the preoperative outcomes. So this is something that is very clear. This is a patient that will need axillary radiotherapy. Now we can start discussing about what the quality of data is, and I know half of the radiation oncologists I know would go infra and supraclav. The other half would not go, and both of them have adequately strong arguments and counter arguments with regards to that. But no, just observing the axilla is not an evidence-based policy in this setting.
So this is the point that we need. Yes.
Sorry, my point was not to do axillary node clearance, not to just do observation. We could rely on radiotherapy.
Yeah, I get that. I get that.
I don't agree with clearance on that case.
Yeah, I am completely with you on that. Okay. In the sense that if somebody has concerns about the original end stage, then they should not attempt TAD at all.
Okay.
So if you go for TAD, this means that you believe in TAD and you believe that it is surgically adequate to do that, and then complete with the rest of the original treatment. That would be radiation therapy in this case. That's what I'm saying. But no, doing nothing in this axilla, so having a targeted axillary dissection 0 out of 3 and then no radiation therapy, that's just not gonna cut it.
Okay, so the point here is that somebody can choose to do axillary lymph node dissection or radiotherapy, but in no case that we can leave this axilla without anything, at least at the point, until we get some data from the studies that are coming up in the future. So, Panagiotis, carry on.
Okay, thank you. So, eventually we proceeded with a level 1 axillary lymph node dissection, in which we excised 16 additional lymph nodes from the right axilla. And again, they were all negative for cancer. So in total, we've got 19 lymph nodes, 3 of them being excised during the targeted axillary dissection, 16 of them during the level 1 clearance. So from this point on, do you think that the patient would definitely need whole breast radiotherapy, and what else? Nothing further. Radiotherapy to the non-dissected part of the axilla plus regional radiotherapy, including the supra and infraclavicular areas, or radiotherapy to the non-dissected part of the axilla only. Again, I would like you to cast your votes. Can we see the table on the screen, please, with the options?
I think
Thank
here
you.
we come to the option of Mr. Dimopoulos now. So I think Thanasis will be happy with this option now.
I'm really happy, yeah.
And let's vote. What do we think about it?
Yeah. Okay, thank you. Can we see the results, please? Thank you.
That's a good one. So we have splitted answers. No further management. So we believe that the lymph node dissection is enough to give us all the information and secure the axilla. We have 49-50% of the people think that we need to complete the management with radiotherapy to the all other areas, and another 24% believes that only radiotherapy to the non-dissected part of the axilla is enough. Mr. Dimopoulos.
Yes, I think that at the moment, at least at the moment, the recommendation is 2. And wherever we look, we will find this recommendation, which means that we have to treat the patient with radiotherapy according to the maximal stage that we have at diagnosis, and not that what we have at the time after neoadjuvant chemotherapy. So for me, it is clear that it has to be the answer 2. At the beginning, we had a N1 and positive situation. And after neoadjuvant chemotherapy, we have N0, which means that we have to go for 2. We have to irradiate the supra-infraclavicular region and maybe parts also of level 2, and of course also the remaining breast. So my opinion is that until we have results from ATNEC and also from NSABP in 51 trial, we cannot do anything else than irradiating such patients.
Thank you very much. I think you covered the whole thing here. Does anybody else wants to say something different than that? I think we all agree that the guidelines say now that answer 2 will be the most appropriate management of this patient. If anybody disagrees with that, I don't think that anybody disagrees. So let's carry on, Panagiotis.
Okay. So, as we said during the presentation, the patient developed some rare but severe complications from the administration of the pembrolizumab, the immunotherapy. In particular, she had hypophysitis and myocarditis. So, taking that on board and into consideration, would you think that the patient needs to take additional pembrolizumab in the adjuvant setting, post-operatively, to complete her course, or you feel that pembrolizumab can be safely omitted at this point due to the presence of these aforementioned complications? So again, if we can have your opinion on this, and if we can see the table on our screen with 2 options only, please. This one has 3. Thank you. Okay, you have 15 seconds again. Please cast your votes.
Yeah, there's only 2 options. Let's see the results. Can we see the results, please?
Thank you.
Okay, most people voted 78%. Pembrolizumab can be omitted. Mr. Koteas, Ilias, what do you think about it?
Yes, combining platinum anthracycline taxanes with immunotherapy is a very effective treatment, but also is quite toxic. So the benefit from the adjuvant part of pembrolizumab is very modest. So additionally here, our patient has developed irreversible immune-related toxicity. So I think I would definitely opt for the omission of the adjuvant part of Pembro. Thank you.
Can she get any worse by taking pembrolizumab? I mean, this patient, do you think that she can get any worse now? Because I don't think there are reversible complications what she had, but will she get any worse if she gets pembrolizumab?
I think most probably.
Most probably. Does anybody else wants to say anything about this? Because we are running slightly late. No. Okay, but obviously pembrolizumab did the job despite the side effects. And I think we should thank pembrolizumab for that. Panagiotis, carry on.
So that's all from me. Before I complete my presentation, just to mention that these are very rare complications. So in literature, they're like 0.5 to 0.8%, the hypophysitis, 0.5%, and definitely less than 1% for myocarditis. Other complications are much more frequent, like hyperthyroidism or hypothyroidism. They say that if it's co-administered with chemotherapy, possibly the incidence of the complications goes up, but it hasn't been clarified yet as to how much they increase. So that would be all from me. Thank you very much for your attention.
Thank you, Panagiotis, for the excellent presentation. I think you warm us up for the next case. So would like to ask for my friend Konstantinos Zaharyudakis to take the stage and present us a more difficult case, a case that didn't go that well with the treatment. Konstantinos is consultant oncoplastic breast surgeon in the Wigan Leigh NHS Foundation Trust. And Konstantinos, the stage is yours.
Thank you. Thanks, Sophocles. Let me try to share my screen. Give me a sec. Can you see my screen now?
No, can only see you.
One second, give me a second. You should be able to see the first slide.
Yes.
Thank you. So I'd like to express my gratitude for the invitation to speak at this webinar. The Hellenic Society of Breast Surgeons has demonstrated a continuous commitment to advancing evidence-based surgical knowledge, and I'm grateful to be part of this effort. So without any further ado, I'll proceed with the presentation. So no conflict of interest to declare. So a 31-year-old patient presented to our symptomatic service complaining of a lump in her right breast. Onset of her symptoms was 4 weeks ago. She has no past history of breast disease. She's a non-smoker. She has no significant past medical history and is on propranolol for anxiety only. Regarding her family history, her maternal grandmother was diagnosed with breast cancer at the age of 45, and she also has 2 maternal aunts diagnosed with breast cancer, AIDS, unknown at diagnosis. So her BMI was 32.3. She's a D cup size with grade 2 to grade 3 ptosis. On examination, there was a 2-centimeter palpable lump located in the right upper outer quadrant at the 10 o'clock position with suspicious clinical characteristics, P5. No skin tethering, no nipple discharge. Clinical examination of the axilla was normal. Ultrasound scan of the right breast revealed the presence of an irregular solid mass with multiple small satellite nodules. The overall size of the lesion was 28 by 19, and the appearances were consistent with the presence of a carcinoma. Ultrasound scan of the axilla showed 2 enlarged nodes visible low in the right axilla, and a few axillary lymph nodes that exhibited cortical thickening higher up in the axilla, so U5, A5. Mammography showed the presence of an irregular mass in the right outer half, measuring approximately 30 by 28 millimeters. The appearances were those of carcinoma. M5. We did an MRI with contrast and it showed in the right breast a 29 millimeter lesion within the upper outer quadrant. Again, suspicious. MRI 5. In the right axilla on MRI, there was only a single 40 millimeter rounded abnormal looking lymph node. The rest of the lymph nodes had a normal appearance. The other side was normal. So this is the MRI. An ultrasound guided needle core biopsy of the breast mass was performed along with placement of a marker clip in the breast and an ultrasound guided needle core biopsy of the largest lymph node. The breast biopsy confirmed the presence of triple negative grade 3 invasive ductal carcinoma. Ki67 was 48%, and the axillary lymph node biopsy confirmed the presence of metastatic carcinoma LB5. Staging did not reveal any metastatic disease. So this is first question. This is a hypothetical question, but if you were to proceed with surgery first, what type of procedure would you do? Would you do a wide local excision and a clearance, a wide local excision combined with an oncoplastic procedure and a clearance, a mastectomy and a clearance, or a mastectomy with immediate reconstruction and a clearance? Can we please show the questions?
So obviously that question goes in 2015, before the big studies.
Yeah, it's a hypothetical.
Yes, exactly. Just to clarify things. I know it's shock now to discuss about this, but there's a point I assure you about that for this question. Okay, let's see the results. So most people would do wide local excision with oncoplastic procedure and clearance. Okay, Giuseppe, what do you think?
Sorry, can I ask?
If I were in 2015, I would have done a wide local excision plus an oncoplastic procedure and an axillary section. 2010, maybe.
Can we comment on the question? There's another question afterwards, and can we comment in both questions? Because it's related. Is that okay?
Yeah.
Yes, whatever you like. Yes.
Yeah. So the next question, which is like related. So this is not a hypothetical question now. So, but okay, the patient should have, in your opinion, genetic testing and again upfront right wide local excision and axillary lymph node clearance, neoadjuvant chemotherapy followed by either a wide local excision or a mastectomy and a clearance, neoadjuvant chemotherapy followed by a wide local excision or a mastectomy and a sentinel lymph node biopsy, dual technique, at least 3 nodes if radiological complete response, or neoadjuvant chemotherapy followed by either wide local or a mastectomy, depending on the response, and a targeted axillary dissection if, again, there is a radiological complete response.
Okay, so it's not hypothetical now. We're going to real world now.
It's a proper question. Yeah.
Yes. I think. So mostly it's a question whether we believe or not in doing staging of the axilla after neoadjuvant, and whether we believe in central and lymph node or TAD after neoadjuvant. So let's see what people voted. So most people believe that we should stage the axilla and spare the axilla after neoadjuvant chemotherapy, which is good news. And they're split between the value of central lymph node biopsy versus TAD, which the debate of the days. I think we should ask which one now to speak. Theodoris, what do you think?
I would have done TAD, but to me it's clear that it doesn't matter if you do sentinel node biopsy with 3 lymph nodes, if you will find 3 sentinel nodes, or TAD. The most important thing is to do it correctly. Don't assume that when someone is doing TAD or doing sentinel node biopsy after neoadjuvant is doing it right. If you're doing it right, for me, it depends on the protocols and the practice at your hospital.
I think the false negative is comparable. Yazan, what do you think about it? Because there are 2 schools in the USA, the ones that they're supporting central lymph node biopsy only and say that TAD is useless, and the other one saying that TAD is the best option and central lymph node biopsy is associated with high false negative rate. So which school is the best school?
So for me, I would do a TAD because you know that you're getting that previously involved node out. And sometimes, especially with the HER2 positive disease, that previously involved node, even with a clip in it, you know that you got the correct node out and you don't find any evidence of any previously involvement with cancer. So you cannot confirm that you got the correct one. The only confirmation is the clip because of the amount of response that has happened months ago. And sometimes the scarring is minimal. Now, I don't think I don't think you'll find that there's any survival benefit as long as you get 3 or 4 nodes. So there's nothing wrong with the sentinel node biopsy, but I think the TAD is much more accurate false negatives should be much less. And I know there's always the argument, should we sentinel node biopsy enough, or is TAD is needed? You need to look at the future. You don't need to be narrow-minded and look on only the present. Yes, sentinel node biopsy might give you the answers and might be the correct management. But if you want to push the boundaries, then you need to be as accurate as possible and getting those nodes out, because that might have implications. If you miss that little node that might have small residual disease, that might have implications on further systemic treatments, and that might have implications on how far you can push the boundaries in the future.
Maria Luisa, do you agree that TAD is the best option here?
Yeah, I think that we obtain a fantastic balance between the third and the first choice. And I think it reflects nowadays, it's a snapshot of what is currently occurring in several countries. So I think that both options are fine, and we cannot answer at the moment since data are not solid and mature yet.
I think Theodoris put it in the right way. If you know how to do it right, I think that's the most important thing. Do it right, and both ways are acceptable, I guess. So, Konstantinos, can you carry on, please?
Yeah, can I ask a question to
Yes,
the panel?
yes.
Okay, so for the people who will do a sentinel lymph node biopsy, let's say you do a sentinel lymph node biopsy, but you only identify 2 sentinel nodes, meaning hot or blue or suspicious. What would you do then? And would you accept that as staging of the axilla? Yeah.
Probably we should ask the oncologist. Since at the end of the day, the decision is in their hands. But it's a good question, absolutely.
This is an excellent question, and thank you for asking me, because I'm Italian, and in Italy they are still doing sentinel node biopsy afterwards without doing either the dual tracer or the TAD. I'm one of the few that uses the TAD. I would go for the TAD, and obviously if I have only 2 lymph nodes, well, I can use a frozen section. I can ask my pathologist to check for the number of lymph nodes. In that case, I would go for an axillary section.
That's a good answer, because we know that 2 nodes are not enough. We know that the false negative rate is quite high, and yeah, I think it's a good call, despite the fact that we're sacrificing the axilla to be as accurate as possible, as he has answered previously.
I think that I know that I know the toxicity of doing an axillary section, but nobody's going to die for an axillary section in 2023, not a devastating surgery. And I don't want to miss a good staging for my axilla. So all 3, well, I do a TAD, otherwise dual tracer with at least 3 lymph nodes.
Hey, Vasilis, would you like to say something about it? If you do a central lymph node and get only 2, what do you do?
Oh, I'm in trouble.
The reason I asked the question is because if we look at the data, the percentage of patients that we actually identify more than 2 nodes is not that high. So if we are defining sentinel lymph node like with a proper definition, like a hot or a blue node, in all the trials that looked at sentinel lymph node biopsy in node-positive patients after neoadjuvant chemotherapy, the percentage of patients that they identified 3 nodes was quite low. So that's the reason I'm asking the question, because this would theoretically happen quite often, where you would identify 2 nodes. The question is now, do you just remove another node that is not a sentinel node to say, okay, I've removed 3 or not, or say, no, I'm not happy, I'm going ahead with the axilla? That's the reason I asked this question.
So Vasilis?
Well, I will try to do, first of all, a sentinel node biopsy. I will do the first section. If we have 3 nodes, I'm okay. If not, I will do the TAD.
Thank you. So move on. Can I move on?
Yes, move on, please.
So let's see what we did. So the patient underwent neoadjuvant chemotherapy. She had genetic testing and was recruited in the ATNIC trial. So I'll just give a brief outline what the ATNIC trial is. It recruits patients with T1, T3, and 1 disease without metastases that are having neoadjuvant chemotherapy. The patients undergo either TAD or sentinel lymph node biopsy at the end of neoadjuvant chemotherapy. And if they have a radiological complete response, only if they have a radiological complete response. So in our unit, we perform a TAD. Patients that have residual disease in the axilla have a completion clearance. And patients that have a pathological complete response in the axilla are then randomized to either no further treatment or further treatment, which can be either a clearance or axillary radiotherapy, which is patient's choice. All the patients I've recruited that were randomized to further treatment, all of them went for radiotherapy instead of surgery. So the next question is timing and type of axillary marking for TAD. So first option is upfront use of a new generation clever localization techniques such as MagSeed or SavvyScout inserted prior to chemotherapy. Second option is carbon suspension-based localization prior to chemo with or without insertion of a clip. Third option is ultrasonographically visible clip inserted prior to chemo, followed by localization post-chemo, any type of localization, or ultrasonographically visible clip inserted prior to chemo, followed by ultrasonographic localization intraoperatively.
Obviously, the time for voting has started, so you can choose whichever you feel is more appropriate. Obviously, all of these things need experience and money and luck, all the last ones. So let's see the results. I'm quite interested in the results here. Can we see the results, please? Oh, this is what expected. Okay. Who would like to discuss these answers? I think Andreas has a lot of experience with all these studies, or not?
Yeah, okay, so I think that most of you guessed what I voted for. No, the thing here is a matter of efficacy. This is a clever answer because both the Savvy and the MagSeed obviously will be incompatible if you feel that you need MRI monitoring in this patient. But we have a solid lesion, unifocal lesion, a mammogram that is completely easy to interpret. We do not have significant discordance in the extent of disease between the different modalities. So you would formally not require MRI monitoring just to monitor the response and to make decisions with regards to surgical planning. So since this is the case, I would feel confident in putting a MagSeed from the very beginning, and that, or put a SavvyScout or any type of smart marker, because this gives the patient one less invasive procedure, which is the clipping, and that's only that. I mean, this is quite straightforward in this sense for me. But if somebody, for their reasons, would like to monitor the patient and the response to chemotherapy with the MRI, then you should just go for a conventional clip that does not have artifacts.
Thank you very much. Anybody else wants to comment about how they do mark the axilla and how do they feel comfortable following up that axilla? Because we all know that these little tiny clips, when we get response, they're not very visible on ultrasound after that. I don't know, Thodoris, what's your experience about that? Do you see the clips afterwards? Is it easy to find them?
No, sometimes it's not easy. I quite agree. We have trouble finding the clips, but unfortunately, in Greek reality, in Greekonomics, we cannot afford to have MagSeed or SavvyScout. These are perfect tools to use, but unfortunately, we cannot have them. I have tried a few cases with MagSeed. It's quite easy, and wish I would also try the SavvyScout in the future. But so far, I'm using clips and wires.
Maria Luisa.
I'm not using carbon because it migrates to other lymph nodes.
Yeah, that's true. That's true. That's true. Maria Luisa, what do you use? What do you like to use in TAT?
Yes, we are going to use the SavvyScout, but currently we are using the ultrasound and the second localization with the wire guided. I think it's a cheap option. It's a very easy procedure and it works fine. A little bit uncomfortable for the patient since the procedure is done the day before and patients need to take the guide the VAR one night, but it was fine, and I think it's a good compromise. The fourth option, I think it has a low reliability, and I think that we can have some difficulty in finding the clip without another additional method of localization.
Thank you very much. Indeed, it's quite difficult sometimes. Does anybody else wants to comment on this, or shall we move on?
Yeah. If I can
yes,
just add something, Mr. Hellenic. So the other thing to consider in this case, if we decide to put a MAC seed, is if we want to mark one lymph node or more, because if we have to mark more lymph nodes in the axilla, the distance between them needs to be more than 2 centimeters to put 2 MAC seeds. Otherwise, it wouldn't work. So that's another consideration to make. And
that's inaccurate. I'm sorry, this is inaccurate. Each MAC seed generates a signal. You remove the first one, and then you remove the other one. There is no practical concern about that.
Yeah, at least it's the practice in our hospital. So the radiologists refuse to put it if it's less than 2 centimeters.
I know it is a common misconception.
It's
a common misconception, but this is wrong because the MAC seed is paramagnetic. So there is no addition of magnetic signal. You just sort them out with the probe because the probe generates the magnetic field and then picks up the magnetic signal from the seed that has been polarized. So this works this way. There should not be concerns about that.
It's very much like taking radioactive reading from 3 or 4 nodes. You take the first node, if there's still reading, you look for the second node. Is that the concept, Andreas? Oh, he ran away from me.
I need to take a cup of coffee, but this is the exact concept.
I hope you're right, Andreas, because I have a case now coming up with put 2 MAC seeds, so I hope it's easy. This is the first time I'm going to do it with 2 MAC seeds.
Yeah, I do it very commonly. What the misconception is what the industry is saying is that you have overlapping diameters, so it's like a Venn diagram of signals. But if you are to scan over an area, then your maximum signal pertains always to focality, so you cannot miss that. And that's a case. That's the same case even if you have MAC seed and MAC trace injected in the same place in the breast. So that's not a concern.
But there's still the 3 centimeter rule for breast lesions. That there is an issue.
Yeah, Kostas, this is a British rule, and there is no data supporting that. Okay, that's a routine, and I mean, especially with the magnetic stuff, I think that I've tortured my life enough years. I know how that works. Don't worry.
So to wrap it up, Andreas, you feel that it will not interfere with a proper central lymph node biopsy?
No, it doesn't. I mean, Sophocles, we always do magnetic TADs, which means that you have a MAC seed in the node, you have MAC trace as the second tracer, and then you have the isotope because it is isotope-based literature. There is never a problem because the highest signal will always be on the MAC seed, so you remove the index node first, and then you move on for the sentinel node biopsy, identifying magnetic, isotopic, and brown-colored nodes.
Exactly. Okay, this is what I want just to sum it up.
Yeah.
Okay, Konstantinos, move on.
Yeah. Thanks, Sophocles. So, okay. So, a MAC seed was inserted under ultrasound guidance in the biopsy-proven lymph node prior to chemo. This is our unit's protocol. So we did initially try placing an ultrasonographically visible clip in the involved node and then insert the MAC seed after completion of chemo, only if there was radiological complete response. But this protocol required insertion of 2 clips, like the clip initially and the MAC seed, in 2 separate sessions, and also the identification of the clip ultrasonographically was quite difficult and technically challenging at the end of chemotherapy. So we then moved to placing the MAC seed straight away. The drawback of this strategy is that the MAC seed is wasted in patients that do not have a radiological complete response and end up having a clearance. We usually only mark the most suspicious node that undergoes FNA or a biopsy, with only a few exceptions, as we discussed before, after we get results from pathology. And there are many different options, discussed by other authors. So the patient declined egg harvesting. For ovarian suppression, she had ovarian suppression as ovarian protection during chemotherapy, and genetic testing was negative for any mutation. So the patient received paclitaxel and carboplatin on a weekly basis for 9 weeks, followed by 3 cycles of epirubicin and cyclophosphamide for every 3 weeks. She did not receive immunotherapy as pembrolizumab was approved in the UK after she started chemo, so we couldn't offer her that. So after the first cycle, she became neutropenic. She developed sepsis, was admitted to the hospital for 3 weeks, and as a result, the second cycle was delayed. Regardless, she completed 3 cycles of chemotherapy. So for follow-up, we perform a baseline MRI, followed by a mid-chemo MRI and an end-of-chemo MRI for all patients receiving neoadjuvant chemotherapy. As Andreas said, the MAG seed creates a large artifact in the axilla, so you cannot assess the axilla via MRI. The axillary response is assessed by ultrasound, and this is part, in any case, of the ATNEC protocol, so we would have to do an ultrasound in any case. The presence of a MAG seed, so a mid-chemotherapy MRI showed partial reduction in the size of the biopsy-proven malignancy in the right breast, which now measured 29 by 20 by 19. Previously, it was 29 by 20 by 26. There were areas of non-enhancement within the tumor, but this could best be described as maybe a honeycomb kind of pattern of response in contrast with a concentric response. And these are images from the mid-chemo MRI. So the end of chemo MRI showed that the tumor is still present as a soft tissue multilobulated mass in the upper outer quadrant of the right breast, now measuring 23 by 28 millimeters. However, there were also new nodules now extending from the tumor towards the skin surface, which were not present on the previous scans, over an area measuring now 39 millimeters. This may possibly be tumor seeding along the biopsy site, which is very unusual, but removal of this area was advised, at the time of surgery. Therefore, the end of chemo scan showed multifocality with residual disease with progression. So these are the images going from superior to inferior of the MRI. And you can see here, I don't know, you can see the pointer, you can see how close to the skin the tumor is, and here you see like an overview of the tumor. Ultrasound scan of the right axilla now revealed between 4 to 5 malignant-looking lymph nodes, measuring up to 30 millimeters. Overall, the disease appeared to have progressed in the axilla, and the number of involved nodes appeared to have increased, though it's difficult to compare ultrasound versus ultrasound. Now, ultrasound scan, we did an ultrasound also of the right breast. We don't usually do that. We did it when we did the axillary ultrasound. And it showed the tumor in the lateral aspect of the right breast had increased in size, and it changed in morphology. And it now had the appearance of 3 distinct masses measuring up to 45 millimeters in aggregate. The inferior-most aspect of the tumor was a 5-millimeter nodule, which was abutting the dermis, resulting in some mild thickening of this region. So the ultrasound appearances correlated well with the MRI. So this is the next question regarding the management now of the primary tumor. So would you perform oncoplastic wide local excision doing breast displacement or breast replacement, skin sparing mastectomy with immediate reconstruction, ADM, and direct to implant, skin sparing mastectomy, immediate reconstruction, ADM, and an expander as a first stage for a second stage procedure, or a skin sparing mastectomy with immediate DF flap?
So we have a case here that actually progressed during the treatment, and obviously the initial question of Konstantinos, what would you do in 2015, which would have been an easy oncoplastic wide local excision and axillary lymph node dissection, switched to some more complicated options now. So let's see what would everybody do here, taking in consideration the outcome. Obviously, you have to do with a very aggressive tumor. Let's see the results. Okay, so oncoplastic, still oncoplastic with its big tumor, 26%. I would like Giuseppe to comment on that. Skin sparing mastectomy with immediate reconstruction, 14%, the least percentage. And most people would do skin sparing with a ADM and expander. Okay, Giuseppe, what would you think? Oncoplastic can cover that?
Yes, thank you very much. To be honest, we are in a very difficult scenario. The disease is progressing, and local control can be not, excellent. And I will need radiotherapy, and I will need treatment straightforward. I will give to this patient a mastectomy, and I will perform radiotherapy, and then afterwards a DF flap. I want to have maximal control locally, because it's progressing locally.
Yanni.
Good morning to everybody.
Good morning.
We have a nightmare here. We have a triple negative disease with progression after treatment. It's a bad sign. I would prefer to perform just mastectomy and axillary dissection. After that, radiotherapy, trying to control the local disease. But anyway, it's bad news because we have a triple negative disease progressing during treatment. Bad news for maybe metastasis after 6 or 12 months.
Yeah, obviously, yes, a tip in the iceberg. And Yazan, what would you do here? I mean, you have similar cases that progress during treatment, isn't it? So that's a mild case, I guess. What would you do in this mild case?
So any progression is always bad news, and this lady will not do well. I would have even put the option of doing a simple mastectomy with clearance without even any reconstruction. I think we need to discuss all those options. I don't believe that the surgery will change the outcome. I think this lady, whatever you're going to do, if you conserve the breast, or you're going to remove all the lymph glands, or going to do a big oncoplastic procedure or reconstruction, she's going to have disease elsewhere soon and will struggle. So for me, I would consider either big oncoplastic, either an oncoplastic procedure with a clearance or a mastectomy with clearance. If she insists that she wants some sort of reconstruction, we'll just put an expander or a temporizing expander just to see how things go in the next couple of years' time. Because if she's progressing on all those treatments, she is not going to do well.
So the message here, and everybody agrees on that, is that we have an aggressive disease, so we go for the least in terms of the surgical procedure, I guess. Andreas, you raise your hand, so I'd like to say something.
Yeah, just to refer to what is out there in terms of evidence, just to clarify some things. There is adequate evidence, especially from the studies of the German breast cancer group, that disease that is progressing during or after neoadjuvant treatment, and this is in line with MD Anderson data, it occurs in 1.6 to 2% of patients, but these patients need to be restaged because they may not have metastases in 12 months' time. They already have metastases now, so you should restage them before making any decision. At the same time, there is a patient-level meta-analysis on European Journal of Cancer from it's a pooled analysis of randomized controlled trials from the German breast cancer group. And just 1 month ago, the I-SPY trial published their data on that on Annals of Surgery. Local recurrence after breast conservation or after mastectomy are completely comparable. So we should not we should not feel that going for a mastectomy gives us better local control in this particular setting. So when you make the decision of what is the least invasive surgical approach should take into consideration the fact that breast conservation is not inferior in terms of local control, or even worse, mastectomy is not better. Okay, that's just what I wanted to lift.
That's a good info. Giuseppe, you raise your hand.
Oh, yes, sorry. No, I was just seeing that in my notes, the notes you sent, there was a delayed DF flap. Obviously, I will do
I think because there were a lot of options. Sorry, yeah, there's some changes compared to.
Clearly, I'm not concerned about. I mean, obviously, I don't believe that local recurrence is going to affect survival of this patient. but I want to have maximal control locally. I mean, this is my choice in everyday clinical practice.
So would you choose a simple mastectomy here?
I will do a mastectomy and axillary clearance and a delayed reconstruction.
Okay, thank you for that. And Maria Luisa, let's take the last comment from you so we can carry on.
I have one question to the oncologist. I would say, well, I think which kind of significance we want to give to the surgery in this case, and if, since this is a very young patient, if it makes sense probably to offer a second option of systemic treatment before discussing about surgery. I mean, since this is a resistant adrenaline cyclophosphamide patient, does it make sense to offer anatetromab and nab-paclitaxel as sort of in the recent trial recently published as salvage neoadjuvant chemotherapy after a failure of the first attempt? What do the oncologists think about it? So are we sure that these patients can benefit from a surgery now at the moment?
But what would you
The
do?
problem-
Would you do
You
a
don't
wide?
want to lose the window. If you lose the window of surgery, you will not be able to
Yeah.
operate on her.
Yes.
So that's the most important thing. If you start trying to change the chemotherapy and she progresses,
Yeah.
then you have committed her to an awful death with huge mass on the chest that you cannot get off and awful quality of life. So at one stage, you need to know when to bail out. And bailing out is not by using oncology again, it's by taking them to surgery.
Also, this in the mid-chemo MRI, she had a response. So this was the result at the end of chemotherapy. So then, as Yazan said, there's a window of opportunity to offer her surgery between like 4 to 6 weeks.
Let's
So-
ask Konstantinos, let's ask Elias. Elias, what do you think?
Okay. I think first of all, the prognosis is very poor here, and we have to consider the main data. That is, this woman has approximately 30 to 40% of 5-year survival here. So we have to be careful what to choose. Okay, so I think, and radiation oncologists I want to answer to make a question for them is how confident they are in treating a chemo-resistant disease with radiotherapy. I mean, this doesn't mean that this tumor may have a response to radiotherapy. So if we opt for lesser surgery, is radiotherapy going to establish, I mean, the same benefits here?
From what I get, you are more into mastectomy than wide local excision, from what I get. And the question is,
I don't think we can treat a chemo-resistant tumor with more radiation, for instance. Okay, I think I would for maximum local control and another systemic treatment.
Mr. Dimopoulos, what do you think?
I think that this is a rapidly growing tumor, and I don't think that we must have the same results as we have with chemotherapy when treating with radiation. So it doesn't mean that a chemo-resistant tumor does not respond to radiation. And my question is, why do you think that the radical surgery will have higher local control rates?
So from what Andreas said, it will not. I mean, the studies from what Andreas said, from what I figure out, is that wide local excision is equivalent to mastectomy in controlling these progressive diseases. This is what I got. This is what I get, I guess, if I'm not mistaken.
Especially for triple negative cancer, that is, yeah. Although there's
sorry, it's not only progressive disease, it's progressive in the skin. And for sure, my MDT will not allow breast conservation in this case. Obviously, we need to see the data that Andreas presented.
So obviously, we're split between mastectomy and wide local excision here.
But obviously, again, I will look for patients' preferences. I can discuss this data. I can discuss this data with my MDT. And if she wants, well, she should be aware that the disease is there is a high chance that the disease will progress systemically. And if she wants breast conservation, I can do breast conservation. But in principle, in principle, my MDT will not allow for breast conservation.
Okay, thank you very much. Actually, we should move on because we are a bit late. So, Konstantinos, can you move on to the next one, please?
Thanks, Sophocles. So, sorry. There we go. So we discussed all options with the patient, including simple mastectomy, followed by delayed autologous reconstruction, immediate implant-based reconstruction, and a therapeutic mammoplasty. So the option of an immediate autologous reconstruction was off the table due to time restraints. So for us, in order to organize an immediate autologous reconstruction, this needs to be planned well in advance, as there is a long waiting list. The patient wanted to preserve her breast. She tested negative for any mutation, so she didn't want to have prophylactic mastectomy on the other side. So she wanted to preserve her breast. Therefore, we agreed to proceed with a WISE pattern therapeutic mammoplasty. Because of the extent of the disease, we used an extended superiormedial pedicle along with a secondary pedicle. So the skin marking that you see here shows the most superior and most inferior part of the tumor. The lower mark corresponds to the 5 millimeter nodule abutting the dermis that was causing thickening, but the skin, this was not T4 disease. We wanted to ensure that the overlying skin was included in our excision to avoid having an involved anterior margin. So the WISE pattern was designed with this in mind. So this is an intraoperative photo showing the skin marking. The limbs were 8 centimeters. On the left, you can see here the area where the tumor was. And the epithelialized superiormedial pedicle and the secondary pedicle that will replace the volume of the wide local excision. The superiormedial pedicle is rotated superiorlaterally, and the secondary pedicle is mobilized superiorly to cover the lower part of the excision. So the wide local excision specimen measured 7 centimeters medial to lateral, 8.5 superior to inferior, 3.7 anterior to posterior. It weighed 120 grams. So you can see in the X-ray of the specimen how the tumor extends in a linear direction inferiorly, which appears to be actually seeding along the needle track from the cortex, the main tumor, and this is the needle track. We also did an inferior lateral save, measuring quite large save to ensure negative margins, measuring 75 by 50 to ensure macroscopically negative margins. And this is an immediate post-operative photo just 4 weeks after the procedure. And we plan to proceed with the contralateral symmetrization 6 months after completion of radiotherapy. So what did final pathology show? So it showed the presence of invasive ductal carcinoma grade 3 in final pathology in maximum dimension superior to inferior. It measured 57 millimeters in size. There was focal high-grade DCIS with comedon necrosis present within the confines of the tumor. Lymphovascular invasion was identified. The closest margin for invasive was lateral. All other margins were more than 10 millimeters, and for DCIS the same. But because we performed the inferior lateral save, even the lateral margin was more than 10. And the next question is, what is the next step regarding axillary management? Would you proceed with a targeted axillary dissection, repeat an axillary FNA or a needle core biopsy, or proceed with a clearance?
Okay, let's see the answers. So most people, considering the aggressive behavior of the tumor, would do axillary lymph node dissection. Would like to talk about it? Michalis.
I voted for TAD, to be honest. I think that there's no strong evidence for or against for that. And I would like to give it a chance to see if we can spare the axilla.
Okay, thank you very much. Maria Luisa?
I voted for axillary lymphadenectomy since I think that if we have a clinical or radiological suspicion of persistence of disease, probably I trust the most to axillary lymphadenectomy.
So you go for the option number 3?
Yeah.
Okay.
Exactly.
And Yazan?
Unfortunately, I tend to be a bit more aggressive for things that have progressed. I don't believe that clearance will make a difference, but I'll still clear her.
Okay.
Oh, please. Sorry.
Sorry, yes, sir.
I have a question to Michalis. In order to do TAD, we don't need to have the radiological appearance of response. Why to do a TAD? I don't think that it is wise to do a TAD in that case.
If you have put a clip in there,
okay,
already, it is easy to find it intraoperatively. The only cost about it is to put a clip in the beginning, so you have done it. And second, for those who do it, a frozen section intraoperatively. It has happened to me that I have a big node that it is full of fibrous tissue and no cancer cells in there. What is the cost of attempting TAD if the clip is there? What's the cost of it? Nothing.
Yes, but I mean, when you're doing TAD, it's something particular. You're removing the clip node and you're doing single node biopsy. In that case, we have a disease that progresses. What are we talking about to do TAD?
Are you sure that first of all, this patient is going to die from metastasis?
Then
he's not going, and I would like her to die, and I would like her to die. No, without a lymphedema. She's going to have radiotherapy. She's going to have a lot of surgical procedures in the breast. I would like to try to avoid a full clearance on her.
For me, it is clear
now,
that...
Sorry, let me just finish. If now the TAD is positive, that's another story. I didn't say that if TAD was positive, I would stay there. I said that perhaps it's worth attempting TAD. If it's positive, we can discuss what we do next. If it's negative on frozen section or whatever everyone uses, then why not try to, do some radiotherapy to axilla?
Because the guidance for TAD is to have a radiological response. I agree that less is more, but in that case, we're not talking about that. It's a disease that progresses.
I think we should take Yannis' opinion and just close this comment and move on. Just Yannis, a short comment, please.
Please. I agree with Michalis that sometimes we have no response in axilla radiologically, but in fact, pathologically is a complete response. We can see it more often in HER2-positive tumors, where after post-neoadjuvant, we see a pathologic lymph node, but in fact is completely responded pathologically. Not so often in triple-negative disease, but anyway, if you decide to perform TAD after neoadjuvant with pathologically lymph nodes in ultrasound or in MRI, we have to perform before a new biopsy to the lymph node. If you have a negative biopsy for the lymph node, you can perform TAD. But without negative biopsy for the lymph node, you have to go on with axillary dissection.
Okay, thanks very much. I think we should move on because we're running a bit late. So, Costa.
Okay. Sorry. So we proceeded with an axillary lymph node clearance. So the MAGSID, the node that we had placed the MAGSID was, we identified this intraoperatively and sent it separately, but we don't have the luxury of having frozen section, unfortunately. So, but I decided to send it separately out of curiosity. The MAGSeed node, there were actually two nodes. One of them showed tumor metastasis. Therefore, if we had done a TAD, it would have been positive with perinodal tumor infiltration, 1 out of 2. And the axillary lymph node clearance showed 4 positive nodes out of 17 with tumor metastasis, including macrometastasis. There was also extracapsular tumor spreading. In total, therefore, 5 out of 19 nodes with macromets. So just to answer, the previous question, so we did not proceed with a repeat FNA or a core biopsy, although the trial protocol does allow you to do that. We reached this decision taking into account the false negative rate of a repeat biopsy. Isolated tumor cells or micromets are considered positive after neoadjuvant and might not be detected. We also did not want to proceed with that, considering that there was radiological disease progression both in the breast and the axilla. Therefore, it was unlikely that she had a pathological complete response. And also, this is not very common for triple negative, but it's still around 30%. There's the possibility of having a heterogeneous axillary response to neoadjuvant chemotherapy, where you get lymph nodes with no or partial response, along with lymph nodes with pathological complete response, which can result in a false negative outcome. So that's the rationale behind what we did. So what is the next step for locoregional control? Whole breast radiotherapy along with tumor bed boost. The same, including also supraclavicular and infraclavicular fossa radiotherapy. Again, whole breast radiotherapy with tumor boost, supraclavicular, infraclavicular, and internal mammary chain, or whole breast radiotherapy tumor boost, supraclavicular, internal mammary chain radiotherapy of the whole axilla. Do we have the... Can you hear me?
Yes, yes. Can we get the results, please? Ash, welcome. Nice to see you.
Thank you. Sorry, I was a bit late because I was doing a case.
It's okay, don't worry. So we have split decisions here. I will ask one of our radiotherapists to answer that. Mr. Dimopoulos, what is your opinion about that?
My opinion is so my vote was for 2, which means that I would give radiotherapy to the breast, to the tumor bed I would give a boost, and then the supra and intraclavicular fossa, since we had axillary lymph node dissection in this patient. So the issue of internal mammary chain, I'm not sure if that would add anything to this patient, which has a very rapidly growing tumor. This is one thing. And the other thing is that it still remains a debate what to do with internal mammary lymph nodes. So at ESTO this year, which was 1 week ago, there was still one of the teaching sessions for 1.5 hours. It was a debate of internal mammary lymph node irradiation. So at least half of the radiation oncology community still believes that internal mammary radiation does not add anything to this patient, especially if this is not the central or medial located tumor, what we do not have here.
Okay, thank you very much. Ash, I think you raised your hand about discussing.
Yes, I did. So the question was to Kostas, was it a level 3 clearance or level 2 clearance? Because then your choices will change.
Yeah, level 3.
Okay.
Hi, Ash. Hi, Ash.
Hi, nice to see you. Yeah,
nice.
Thanks.
Shall I?
I think we have a comment from the audience, which is quite interesting. He say she had an aggressive disease, which is chemo-resistant. I'm not aware of any evidence supporting de-escalation. And I think that's a good question because we were discussing about TAD and et cetera, and eventually we had a progressive disease. I don't think we have evidence for that. Does anybody know if we have evidence for progressive disease that we can de-escalate surgery, both in the axilla or in breast?
Can I answer that?
Sorry?
I said, can I answer that question?
Yes, of course, Jason.
Yeah, so that, no, it's Ash. So yeah, we sound the same, both of us. No, there's no evidence. But I think pragmatically, Michaelis made a very important point, is what are you trying to achieve in these cases? Because it's not the local disease in the breast that is ultimately going to compromise your prognosis. It's the distant spread. So for local regional control, you're doing the surgery or you're trying to enhance prognosis. So you need to set out in an MDT what you're doing the surgery for, and then you talk about escalation and de-escalation. Yes, there is no evidence against de-escalation, but there is no evidence against escalation either. So when there's equipoise, you try and get the patient involved. And what Giuseppe said, shared decision making, is we may not be able to alter your prognosis because ultimately systemic disease needs to be treated with systemic treatment. And that's what's going to make a prognostic difference. So what is it that you would like us to achieve? And yes, you will do maximum locally to achieve local control. But that doesn't mean that you have to do a mastectomy every time. But yes, a mastectomy in this case would make sense. A mastectomy and axillary clearance in this case definitely would make sense because it's a progressive disease. You want to give her as much chance locally. And we know that if they relapse locally, then there is a 1 in 4 chance that they will relapse systemically as well. 50% of patients who relapse locally have metastatic disease at the time. So you want to avoid that. So yes, there is no evidence for de-escalation, and you would want to give a maximum control locally. So those are the 2 aims that you all need to discuss in your MDT.
Thank you, Ash, for that. And can we move on?
Yeah. Yeah. So we offered her whole breast radiotherapy, tumor bed boost, and radiation, supraclavicular fossa, infraclavicular fossa, and internal mammary chain. Should I move on? Sophocles?
Yes, I think we covered that. Yes, move on.
Yeah, I think so. So, and I think this is the last question regarding systemic control. So would you offer her capecitabine, no further treatment, or a PARP inhibitor such as olaparib?
Correct me if I'm wrong. You said that she was tested and she was negative for genetic mutation.
BRCA negative, yeah. Correct.
Okay, I'm just clarifying that before we answer that. Okay.
Yes.
Okay, can we see the results, please? Okay, most people voted for capecitabine and less people for no further treatment and PARP inhibitor. Elias?
Yeah, I think it's the only available option we have here. As we have seen before, it's a chemo-resistant tumor. I don't think capecitabine will work, but it's the only option. It's the only option.
I'll ask you a question, provocative question. Since it was not approved before and it was approved after that, can you give pembrolizumab even if you didn't give it pre-operative as an neoadjuvant setting? Can you give pembrolizumab in this case afterwards?
No, you can get a reimbursement for this. No,
you can't give it.
No.
Okay, can we move on?
I missed the start, but did you do basal markers for this patient? Was it a basal-like or a non-basal-like tumor?
It was no, we ER negative, PR negative, HER2 negative. That's
yes, but
what we only check. We don't do basal market. No.
Okay, because giving capecitabine has toxicity as well, and it doesn't. Now there is evidence that it doesn't help in basal likes. It helps in non-basal likes. So if you have a basal like tumor, you give a patient capecitabine with a lot of side effects and have no benefit at all. So you should go back to your pathologist before you make this decision. Ask them to go to the original core biopsy and ask them to do the CAM or the CK, whatever they do. And that's how you decide whether you give capecitabine or not. It's not just every patient. I know the Korean paper gave everyone, but when you look at that paper and do subgroup analysis, it only helps in non-basal likes, not in basal likes.
Yes, I agree with this, but it's a subgroup analysis, and the current guidelines don't have the options to choose if it's a basal-like or not. You just give it. I know it may not work. The most probable scenario here that it is not going to work, but I feel we are compelled to give this treatment now, irrespective of basal status.
Okay, thank you very much, everybody. I think, Konstantinos, are you closing it or do you have more?
That's it. Yeah, I'm clear. Yeah.
Okay,
So,
thank you everybody very much for this interactive discussion. And I will now ask Michalis to take the stage and introduce the next speaker and move on with the next case, which is more difficult. If you thought that cases up to now that were difficult, try to see the next one.
Hi again. We could go on discussing about the last case, about what Ash said for a long time. I agree about base alike, non-base alike, etc. But let's move on because we're half an hour behind. I would like to call Yazan Masanad to the microphone, and Yazan is going to present a tricky case of a 20-year-old patient and her management. Yazan, we're all ears.
Thank you for the invite, and I must say this is not what I would usually do for every patient, so I'm trying not to give the wrong messages from this case, but I thought it is worth sharing. We'll try to buy some time. We might not need to take the full half an hour for this. So we had a 29-year-old lady coming to the clinic with what looks like a small area of induration, 3 centimeters, looked like an abscess, started as what she described as an insect bite when she was on holiday and was seen by one of my colleagues mainly 2 or up to 4 weeks after this all started. She's been on antibiotics for a couple of weeks and there is little or no improvement. There's no family history of breast or ovarian cancer. She's fit and healthy. She has no children. The only thing is that her BMI is quite high. It's 39. She has a D-cup breast and there is no discrete masses, but in the inner part of the left breast, there was this area of induration. There's no skin lymphedema, but there's some redness and thickening of the underlying tissue, and the axilla felt normal clinically. So ultrasound scan showed no collections, lots of tissue changes and inflammation with subtle hypoechoic area just close to the pectoralis major. Indeterminate, not very convincing of anything. And the axillary ultrasound scan showed 3 or 4 reactive nodes. The largest was cortical thickness of 3 millimeters. And we've taken a biopsy from that subtle area behind the inflammation, close to the pectoralis major, that showed nothing specific, just some inflammatory changes. So the usual next step of management, what will you do for this lady? We'll just reassure her and discharge her. We'll just change the antibiotics and review in a few weeks' time, arrange a mammogram, and if it shows nothing, then reassure, punch that skin and do an MRI scan. What will be your next step of management if you want to take the poll here?
So please vote now. I think everyone must have voted. So 3, 2, 1, yeah. So most people thought that we would like to do a punch biopsy and MRI scan. So they're being very suspicious. So who voted for choice number 4? Thodori, did you vote for 4?
Yes, Michalis, I voted for number 4 because it rings a bell. I had in my practice a similar case that it was an infrequent tumor, and I think that the diagnosis was done by a punch biopsy.
What is the fact that led you believe that it is not an infection of some sort?
Yes. If it doesn't show like an infection or a mastitis, it's not granulomatous mastitis, it's not periductal mastitis, it's not something that that you can have a diagnosis and it remains the same with antibiotics. I think the next step to move on is to take a punch biopsy and of course to do an MRI to see if there is something unusual that you are missing.
Ash, what do you say?
I think what Yazan is doing in this patient is doing blood tests and showing us the blood reports and inflammatory markers. So if she's got this infection, supposedly infection ongoing for some time, she should have raised CRP, she should have raised ESR, and she should have a high WBC count, which has not been shown to us. So in fact, I didn't vote for any of these, because if you do a punch biopsy and comes back as negative, that's falsely reassuring. An MRI scan in the presence of an infection is going to show you exactly what it's going to show you in presence of an aggressive cancer. It's going to do a lot of pooling. I would just review this patient in a couple of weeks to see what's going on, because changing the antibiotics is not going to give you anything in the absence of any blood markers that are raised.
Sorry to interrupt you. Good morning first. Sometimes also the inflammatory markers are negative in these cases.
No, so we're all being very clever.
Because rely on
can I just tell you something? See, you have to think of this case as a patient who comes to your outpatients, not as a patient who's being discussed as a difficult case in a cancer MDT.
Okay.
Because all of us are very clever because we all know this is a cancer coming up. So we will all vote for the clever stuff. You ask yourself, if you see a patient who's coming to your clinic, would you do an MRI scan first off? Would you do a punch biopsy first off? Or would you review that patient? Would you change the antibiotics? Every one of us has one patient that we've missed of inflammatory breast cancer. This doesn't tick the box of inflammatory breast cancer. No. And what Yazan has also said was a 3 millimeter cortical thickness. In our unit, 3 millimeter cortical thickness node would also be biopsy, because 2 millimeters is the cutoff. So 3 millimeters.
I think we will all agree that we cannot discharge her. Say to her, go home, change antibiotic, go home, and bye-bye. So we should do something about her. The least we can do is see her again in a few days or weeks. So, Yazan, what did you do?
So I agree completely with Ash. The problem, we did not do any bloods because we don't always do bloods on the first presentation with an query infection. And we just changed the antibiotics, thought we have a biopsy that's negative. It's a bit reassuring. Our cutoff in our unit is 3 millimeters, but I know that many cutoffs for other units is 2 millimeters for the cortical thickness. So we thought we'll change the antibiotics, see how things go, and we'll see her in a couple of weeks' time. And within a week, she started phoning again, say, there is bruising in the breast, the redness is a bit worse, she has pain in the breast and the axilla, and the pain is new, and she feels that the breast is getting worse and she's not feeling great. So we brought her back to clinic. We had an ultrasound scan that showed an organized hematoma, and the organized hematoma now started to get infected. But now, within 2 weeks' time, that area of hypoechoic area became more like a mass, about the pectoralis major, and the node is getting bigger quickly. It's about 3 centimeters, abnormal looking node. So what will you do here? And I agree with Ash, we should not be jumping into doing punches and MRI scans and everything. You take it step by step and then see what you get. And we all have missed cancers, and we all had inflammatory cancers that came differently, or local advanced aggressive cancers that presented differently. So what will you do here? Will you just aspirate the hematoma that is infected and just send for culture? Will you repeat the biopsy of the breast and the axilla? Will you monitor and continue the antibiotics because you have an infected hematoma now that will explain some of her symptoms? Or will you do the mammogram and monitor?
Let's have the voting box, please. Let's see, and vote. Vote now. We have 4 options, not 5. Stop voting. Mr. Andreades, 4. Vote now, please, and submit your vote.
Okay, meanwhile, we have a question from the audience. Would have anybody used ibuprofen to reduce inflammation and maybe see more clearly on imaging along with the antibiotics?
Our issue is now, Sophocles is now, she has raised inflammatory markers because she has infected hematoma.
Obviously, the question went to the initial presentation. So let's see the results.
Let's see the results, please, now. So most people voted for answer number 2. So repeat biopsy, both breast and axilla. I have to agree with Ash. Now that we're discussing here in an MDT, a cancer MDT, it's easy to say that we are, redo biopsies, we're very suspicious of cancer, etc. Who should ask? Panayoti, what did you vote?
So yeah, at this stage, I think we would do a biopsy in both the breast and the axilla. I totally agree that at the beginning, I personally would go with continued antibiotics and review in 1 week or 2 weeks. We would not very frequently do an MRI for any patient who comes with a breast and what appears to be a breast inflammation, especially after a reported insect bite. So we would go conservatively at the beginning because common things are common. But at this stage, I think we have convincing evidence that we need to do something more. Definitely a mammogram would not be a good option in an inflamed breast. It would be too painful at this stage, but we definitely need to do it once it subsides. So I think we should look for the results from the biopsy at this point.
Anybody else that voted for choice number 3 or 4? Giuseppe, what did you vote for? Is having coffee. Andreas?
So just out of rigidity, I have to say that whoever presents to the clinic with inflammatory-like symptoms, they undergo standard blood tests in the unit, and this is the regional policy as well. When they are contacting us from primary healthcare and they are suspecting a mastitis in a woman that is not breastfeeding or is not an active smoker and a little bit younger, I tell them that please take blood tests. That's the one thing. The other thing is that we do have a very low threshold in investigating for suspicious symptoms for cancer in that. So I voted for the first one for the thing that I would have done, and I would not have done punch biopsy and MRI. I would have done MRI and punch biopsy afterwards. But at this stage, you need to discuss nothing else than histological confirmation, because it is clear that you have clinical progression of anything, since we do not formally know what this something is right now, but you have clinical progression and somebody that is actively telling you that this is not going well. So in line with what Dr. Horty said, yeah, the mammogram would not offer that much. Aspiration and symptomatic controls or monitoring, they are not due anymore, even if somebody had considered them before.
So Andreas, what you're saying is that since she's progressing on treatment, we're giving her the wrong medication. So think of, okay.
Exactly.
So Yazan, what did you do?
So at this stage, this is when she came to me, and this is when we sent her to have repeat biopsies. And the biopsies showed a poorly differentiated cancer, high grade, very necrotic in the breast and in the axilla. In fact, we had little viable tissue to do immunohistochemistry. And on that little viable tissue, we managed to know that this is triple negative malignancy, looking most likely to be primary breast, could not do any basal markers, could not do anything extra. And by the time she came back to clinic, that's a week or two after, because we have lots of delays in the pathology, she already had a fistula from the hematoma. The breast was already disfigured. The pain was getting worse, needing regular paracetamol and non-steroidals, and starting to investigate if we need to start giving her opiates, and the whole breast was a mess. So what will you do next?
So the options are complete imaging of the breast, genetics, staging investigations, given the speed it is progressing, refer to oncology, or all of the above. Can we have the voting box, please? 5 choices to choose from, 5 answers. Three, 2, 1. Sorry, let me submit my, okay. Let's see the answers, please. Yeah, it's pretty obvious.
So we need to do lots of things for this lady. Yeah.
We have to move fast because we don't want to let it move faster than us. Right. I think it's not worth discussing it further because it's pretty obvious what we should do. So what did you do, Yazan?
So she managed the mammogram with difficulty, and you can see the mammogram, you can see the breast lump. So they had the mammogram after the biopsy, of course, you can see the marker coil, and even the axilla, you can see the ping pong there. And this was her breast MRI scan. She's getting worse and worse by the day, and you can see the whole pectoralis. There's enhancement even in the pectoralis. It's pulling on the pectoralis. That's why she has the pain. And that's her CT scan, and you can see it invading the pectoralis with all the changes around it. And you can see the axillary node on that CT scan, but no other disease anywhere else. So we just took her to the oncologist, say, please start as soon as. They had a look at her, and within a week, they started, admitted her for the IV antibiotics and started on chemotherapy. At that stage, a couple of years ago, we were starting to do Pembro, so they gave her also Pembro with that. And we're not going to go through the chemotherapeutic regimes here because different places will do different things. The genetics was negative for this lady, but she had still an open fistula. The tumor was starting to fungate, but once she started on the Pembro and the chemotherapy, she started feeling better. So the pain in the chest wall was better. The pain in the axilla was already better. And you can see a bit of response in the breast, though the breast most of the time was dressed because it's locally advanced, just going all through the skin in a big patch that you cannot take out. So after halfway through the chemotherapy, you can see the improvement in the breast and the axilla. There wasn't many nodes that you can feel in the axilla clinically because on examination, there's not much there. On imaging, it has responded well. And then problems started again because she started to have all the side effects from the Pembro, not tolerating it well. The breast started getting infected more and more. So the chemotherapy and the immunotherapy was not delivered according to plan because of all the problems. And after finishing halfway through chemotherapy, she started to get more pain in the axilla, needing more opiates, cannot sleep at night, cannot mobilize much. And this is a 29-year-old, very young lady. Clinically difficult to assess, but felt that she improved initially, but she's progressing now. And the CT scan, repeat CT scan showed progression in the axilla, prominent internal mammary nodes, pretracheal nodes. The breast looked stable, but you can see that it is better than initial presentation, but worse than halfway through. And you can see the axillary node is getting worse and worse. We had a look at her with the oncologists, and there's no way that we can do anything surgically for her at that stage. Her quality of life was awful. What would you do next? Would you just continue systemic treatments? She's failing on most of systemic treatments. Will anybody venture into operating on this lady? Will radiotherapy be an option, or will you just give her symptomatic management and that's it?
Let's see the voting box, please. The answers, please. Bring up the answers, please. So most of people voted for radiotherapy. And then the rest of the answers are split between continuous systemic treatment, which is not working very well at the moment, and surgery. So, Maria Luisa, I have to ask you now, what would you do in Yazan's case, in Yazan's position?
This is a very challenging situation.
Yeah, I was saving that for you.
Well, honestly, I answered radiation therapy since I think that the systemic treatment is not working anymore, or probably it didn't work, and I cannot see a space for surgery in this case. We can offer less opportunity as radiation therapy, and after that, funding surgery. But I think that radiation therapy may be a reasonable option in this case.
So you go for radiotherapy?
Yeah. I don't know if you agree.
I think it's a valid option. I would ask whether I would ask Elias Koteas if we could change perhaps the agent we use for chemotherapy. That would be another, I don't know, alternative. Will it, Elias?
I think there's another hard case of one progressing on neoadjuvant treatment. I think we don't only have a progressing disease, but we have a systematic disease now. Okay, so I think despite that I'm usually in favor of local treatments when applicable, this is not the case, I'm afraid. And I think we have to forget about immunotherapy and chemotherapy and try a second line treatment. This is how I call it, and which is sacituzumab govitecan, an anti-TROP antibody with very good results as second line therapy. So this is my option here with no any local treatment.
Elias, you say just change the medication, change the drugs, and hope that they will work.
Yes.
I have a question now to make to everyone, and I know Ash wants to say something, but Ash, give me 1 second, please. If this disease right now is still operable, even if with a very radical procedure, and since we don't have, and since this disease, the local disease is the one that causes the problems and compromises her quality of life, why is not a valid option to resort to a very big surgical excision without any reconstruction and axillary clearance? I'm just putting it up there for discussion. Ash, what's your opinion on this?
I think what Yazan said was the patient was not operable. Yazan, correct me if I'm wrong.
Yeah, at this stage, I don't think I could have taken this out.
Because of?
Oh, the extent of the skin changes. You will not close. You need either a huge flap, which is not going to be good for her, or you need even advancing the abdomen would not have sorted it out. And from the amount of pain in the chest, I couldn't move it on the chest wall. So I did not think that surgery will be a great option here. We're not talking about curative surgery. We're talking about palliative surgery here.
But I think, Yazan, the point that Michaelis is making, and I understand what he's trying to say, is if the patient progresses further on second-line chemotherapy, you've got two competing factors going on here. One is systemic progression, and one is the local control, which is giving her a poorer quality of life. So if it doesn't respond to that, then you probably, I think that's where he's coming from. You probably missed the boat for local control as well.
Which is the main factor that compromises her quality of life.
But can I ask you one question, Yazan, before we talk about surgery and radiotherapy? What panel testing did you do? What genes did you test for?
Just BRCA1, BRCA2, CHEK2, ATM, PALP2, the usual 8 or 10 genes that we do. It's not. So
in this case, did you test for TP53?
TP53 was done, yes. TP53 was one of the ones that was done.
And how long did you know? I mean, how long did it take to come back? It takes 8 weeks to come back.
This whole process by this, we're already about 3 or 4 months down the line. So it did take a while. So when we do, it's the standard panel that we have in Aberdeen is BRCA1, BRCA2, ATM, CHEK2, PALP2, TP53. There is a couple of others. There are about 8 or 10 genes.
Yeah. Okay, this is NHS panel.
Michaelis, since most people voted for the therapy, shall we listen to the opinion of Mr.
Yes, I was about to ask Dr. Dimopoulos.
I would go for radiotherapy because radiotherapy in this case has to be considered as palliative. And the next thing is most probably if there is a lot of pain for this patient, this means that we have an invasion of the brachial plexus, most probably, yeah, which means that there is nothing else which can help this patient. And the other thing is that this is, of course, only palliative because this is not oligometastatic disease. This is not a slow progressing disease, which means that we are going only to apply this treatment in terms of palliation. And then you can continue systemic therapy.
And that's exactly what we've done. We thought that this has gone through chemo, immunotherapy, first line. second line, still progressing, nearly spending most of her time in the hospital, extremely poor quality of life, lots of pain on high dose opiates already on the pain team. And we thought, I cannot take this out. So we got the oncologist and they irradiated the breast, irradiated the axilla and the internal mammary chain, mainly for local control and see how well she responds to that. And in honesty, the breast responded better. The skin was much better. The tumor was still quite large, but the skin has improved significantly. The axilla was an issue, and the axilla, you can feel that the node maybe have got slightly bigger, but might be because of necrosis rather than progression. And it was mainly, the pain was mainly in the chest wall and that where the tumor is. And in the axilla, it wasn't a plexopathy. It was just because the node is starting to invade through the muscles. So after the chemotherapy, we've done a PET and staging CT scan. Sorry, I'm trying to rush through this. I don't want you to overrun more and more. So this is what we had from the PET. There is a bit of improvement. It is involving the PEC measure. We're not sure if it's reaching the rib or not, but the rib, the cortex seems to be intact. We think it's not. This is the lovely node in the axilla that was just involving the PEC major and minor, but about a centimeter below the vein. Now, the question here, we know that we cannot cure this lady, and I don't usually operate on those ladies because we know that they don't do well, but this is a 20-something-year-old, cannot sleep at night because of the pain, cannot move her shoulder at all because of the amount of involvement in the axilla. Is there any role for surgery?
Keeping in mind that we have missed the window of opportunity once, perhaps.
Yes, because this is progressing by the week. It's not you see huge difference. Initially, in the first two presentations with the negative biopsy was seen by somebody else and then ended up in my clinic. And you can see she had presented a trail of photos that is scary to see the amount when it looked like like an insect bite, from when it looked like a completely deformed breast was 6 to 8 weeks time.
Let's see the results now, please. So most people voted that perhaps we should take advantage of this response to radiotherapy. It is difficult to operate on a tissue that has been received radiotherapy in the recent past. Is Giuseppe with us? Yannis Natsiopoulos going to say something.
Yes, thank you, Michalis. This is not a hard case. This is a nightmare because we have a young lady with a rapidly growing disease, a progressive disease, local controls, complications from systemic treatment. We had a similar case some years before. The lady was very young and finally she died after 6 weeks with liver metastasis, bone metastasis. We had previously performed radiation, change of the systemic treatment. Every attention to this case for local control is only palliative. Everyone knows it. Maybe a chance is to change the regimen, to change the systemic treatment, to try to stop the disease. Every other attention, I think, is useless.
So, Yannis, you voted for no surgery?
No role for surgery because we give her 2 or 3 weeks of palliation, and after that, we'll try to face the metastasis.
I see. Andreas, what did you vote? Not in the national elections, just for this one. Which are tomorrow, by the way. Tomorrow we have the national election.
Yeah, well, so I think that the tenet that desperate situations call for desperate measures does not apply here, in the sense that, okay, we are talking about palliative intention, perhaps. But I agree that we will not be offering that much. That is, of course, if we have decided on this being palliation. I am aware of an ongoing UK trial that stems from a Japanese study that was prematurely paused because of high effectivity. I would consider, in terms of local control, neoadjuvant radiotherapy with or without peroxide injections in that, just to make things a little bit more interesting for the discussion. Because if we could have better local control without putting the knife into the discussion, then we would be discussing on a different basis. The concern here is that just extrapolating from the randomized controlled trials of surgery in the novometastatic cancer, this is a patient that has got systematic disease. I think that it was very wisely touched upon before in the discussion. I don't see how surgery would achieve much more than just a very transient alleviation of symptoms, but at the same time acceleration of the metastatic disease. That's my 5 cents on that.
So Yazan, what did you do?
Well, I wouldn't usually do this, but she was really symptomatic, lots of pain, and I took it out. So it was a nightmare operation. So I've done a mastectomy, and when I did the mastectomy, I left the pectoralis major. I felt like Halsted. The tumor was going through the pectoralis major, as you would imagine, but not on the chest wall. And the axilla took a couple of hours of going through cement. But I advanced the abdomen and closed the abdomen. Day one post-op, the first thing that was noticed is that we nearly stopped most of her analgesia that she was on for the past few weeks. And her quality of life was better. We know that, and was very clear that this is only palliation and this is not going to cure the problem. And many people will disagree that we should be doing this at all. But I think in her case, it has made a difference. We know that she's going to die from metastatic disease. She's still alive 6 months down the line. And but now she has, of course, as you expect, metastatic disease with that aggressive disease. But her quality of life was much better for the few months before the metastatic disease started, mainly lung problems. So I know that many people will disagree with that. Many people will think that this is mad, but this is mainly for local control, not for local symptoms.
If I can interrupt, I do not disagree. We have all been involved in similar cases, and we have done aggressive things. So just to make my point, I have resected and reconstructed the chest wall, putting titanium plates and meshes and having the plastics, doing a DIEP to cover the defect because that was huge, and so on and so on. That particular patient that needed morphine ointment in order to be able to change the dressings, it went better for her. And then on clear margins, you had skin metastases 4 or 5 weeks later. But the issue here is that you can never tell. I agree that we have to discuss the concept of local control, but I'm just wondering whether surgery is the only option we have for local control in these cases. That's the point that I'm making here.
Right. Because we have run out of.
Can we just one last thing? I'm interested to know what Ash thinks about this.
I need a pathology report here, sir. What is the
exactly? So I was about.
This came back as metaplastic, and we couldn't diagnose the metaplastic on initial biopsies because of the amount of necrosis, and it has shown no response to chemotherapy. It has shown no response in the breast or the axilla at all, or minimum response. And the nodes were I think the nodes were 6 centimeters was the biggest node attached to chest wall with a bit of muscle that came out also. And we had only about 9 nodes after all that radiotherapy and chemotherapy. 4 of them were heavily involved with the extranodal spread. And the tumor was completely excised on the skin margins and was going through the pectoralis major, but not invading all through and through. So the posterior margin was also clear. And that's why she did not have a local recurrence yet, but she, of course, she has a systemic disease now.
So the one question from the audience was actually whether what the final pathology was, and you answered that. And my question is, if we had known right from the beginning that it was a metaplastic carcinoma, would we have changed any treatment, any chemotherapy or less chemotherapy, or Ilias?
Yes, I think metaplastic carcinoma shows very poor responsive to systemic treatment. So I think if we have this pathology, I think I would opt for upfront surgery for this patient, and not systemic treatment. So, but now I think we all agree that surgery and radiotherapy don't have any curative role here. It's only for palliation. So, and I heard that the patient now has stage 4 disease, and am I right?
Yes.
Yeah,
Yes.
and that was very clear. We were very clear with her that I'm doing
Yes.
this for local control. If you want it, I'm not going to cure the problem.
Sure.
Right.
Only I want to mention that metaplastic breast cancer is usually associated with PI3K mutation. So if this woman is such treatment is available, or a trial like this may be enrolling such a treatment with PI3K mutation, should be tested for PI3K mutations, and if it is positive, she may be treated. But otherwise, any other treatment is, in my opinion, is hopeless here.
Right. We have one question from the audience. It is related to the earlier stages of this patient. Yazan, the question is, what is the value of breast MRI in an inflammatory condition? Are we going ever to do a lumpectomy?
So
What's the use of MRI?
So the MRI scan was mainly here for us to see if the extent of the involvement of the chest wall rather than anything else. It was not to assess the extent of the disease in the breast, because you can see that we were not going to conserve her. I wanted to see, because the CT scan will give you a good idea about the PEC measure, but the MRI scan will give you much better idea about how much is the involvement of the chest wall. So the MRI scan was mainly for that rather than anything else. We were not going to conserve her in any form or shape.
Thank you, everyone. Thank you, Yazan, for this case. You made us think harder. And I would like to go on straight to the 4th case for today. I'd like to call Maria Luisa Gaspari to the microphone. Maria Luisa is going to make us think even harder with a very interesting and well described case. Maria Luisa. Sorry, before you start, Maria Luisa, because I mean your microphone may be away from you. Can you speak a bit louder, perhaps, and closer to it, and a bit slower?
Of course, I will.
Thank you.
Thank you. I'm entering in this inspiring and involved atmosphere with a clinical presentation on the topic of axillary management in clinically node-positive breast cancer patients converting into node-negative after primary systemic treatment. Our patient is a 51-year-old. She's presenting at our attention with a right breast lump at the self-examination. She has no relevant personal and family history, not that she knows at the moment, and the surgical history positive for 3 cesarean sections. At the clinical examination, this patient presents a 2 centimeters lump with a partial retracted nipple and no discharge after nipple squeezing. No apparent infiltration of the skin and neither the nipple areola complex, but 2 suspicious nodes at the palpation in the homolateral axilla. Here you can find depicted the mammography performed at diagnosis, where you can find a cluster of suspicious microcalcification, and already we can see some suspicious nodes in the axilla. At the breast and axillary ultrasound, we found and we confirmed the suspicious node with a size of 20 millimeters with irregular margins, and suspicious lymph node with a high thickened cortex, and another less suspicious smaller lymph node adjacent to this one. At the breast cord needle biopsy, the histology analysis confirmed an invasive carcinoma. It shows an invasive ductal carcinoma with grading 2, with no expression of estrogen and progesterone receptors, with a Ki67 on 30%, with an immunochemistry for HER2 score 2 and a negative FISH. Now my question is, a triple negative breast cancer woman with suspicious axillary node can be defined as CN positive based only on one suspicious node at the clinical and or radiological assessment, or do we need a pathological confirmation through a final needle aspiration or cord needle biopsy, or it depends by the case? I think that now we can vote.
The voting box, please. Thank you, Marilena. Let's see the voting box, please. You can vote now and submit your vote.
We have 10 seconds. I think that we can proceed. 5, 4, 3, 2, 1.
And let's see the results now, please. So most of us voted that we would like a cord needle biopsy of the lymph node, and I would like to extend the first question to Andreas, who I'm sure has many things to say, a lot of things to say. What is the advantage? I mean, apart from the lower sensitivity of an FNA of a lymph node, not the primary tumor, yeah, the lymph node. What's the advantage in comparison to a cord biopsy? I would do an FNA.
So the particular advantage to this very challenging case is the devil hiding in the details. So this is formally a triple negative breast cancer. I see Ash shaking his head now because this is actually closer to a HER2 low. So you have a 5 to 10% chance of getting a HER2 positive lymph node, which will change your treatment. So if you just need to prove metastasis, yes, the fine needle aspiration would work equally fine given the rate. But here, if you want to do the fine tuning, you go for the cord biopsy just to make sure that this is a triple negative and not a HER2 positive.
So you're saying, Andreas, that if this node is HER2 positive, the
then
whole treatment will change
exactly because
for the rest of her life, of the patient's life. Is that what you're saying?
Yeah, I'm saying that you have a case. I mean, there are people that are more passionate about that than myself, but with the start of the Enhertu neoadjuvant trial in a couple of months' time, you will start seeing that the HER2 lows will enter our clinical practice in a completely different manner. I think that this is the reason that I would like to know a little bit more about that would be the HER2 positivity in this setting, because in this case you have to rebiopsy the tumor just to make sure that it is what it is. Otherwise, if you need just confirmation, you can do an FNA and you can just depend on that. But this is why I would like a core biopsy in this particular case.
Elias, would you change your treatment based on a core biopsy of the node?
Yes, and certainly, if this come out to be a HER2 positive disease, yes, certainly. I think.
Okay, then. And Ash is agreeing, I see there, nodding all the time, yes? Ash, you would do a core biopsy here.
I would do, but the question here is actually a bit tricky. Is how would you define nodal status as clinically C1 or N1, sorry. And if you look at all the American trials, the answer 1 would be right. And this question is not about what would you do next. It is how would you define. So my question to the panel is how would you define it?
Palpable ultrasound or biopsy?
Because in the States, not every patient gets all the trials that have come, and Andreas knows this, have come from the States. In the States, they don't routinely do an ultrasound of the axilla.
No, they don't, and that's the case. But I mean, here to call it clinically N1, we try to extrapolate and modernize our colleagues in the United States. So we make them the favor of saying that absence of clinically palpable lymphadenopathy with the presence of a pathological node that is singular would probably classify as CN1, but it is a compromise, so to say. Yeah. On the other hand, I mean, you consider her as preoperatively node positive. That's what you are going for. And since you would formally need an axillary dissection if she were to be treated up front, then you should also consider staging with relation to the subtype. I know that I am a little bit of a pain with staging and restaging, but we are not just surgeons. We have to remember that.
So I know that we are all very clever people on this panel, but there are lots of trainees out there. So I just want to make sure that they understand that even if you have a palpable lymph node, which is not biopsied, you'll still call it as clinically CN1 and not call it CN0 because you don't have histological diagnosis. And yes, I totally agree with you that 7% of all these triple negative breast cancers have heterogeneity in terms of the HER2. So I would definitely core biopsy the axilla and get immunohistochemistry on that as well, specifically for the reasons that you mentioned.
Giuseppe wanted to say something. I think I saw you raising your hand.
Yes, thank you very much. Just to point out that I totally agree. If the question is how would you stage this patient is clinically and on ultrasound is CN1. But obviously I will need to have the information. As for the first case, I will need to have more precise information about the HER2 status even on the lymph nodes.
All right. So Maria Luisa, what did you do?
So I can proceed. We performed a core needle biopsy for 2 reasons. Since I think that the way in which a physician decided to do a diagnostic and invasive procedure is based on 2 principles. The first one is the reliability of the test, and this is why we decided to perform a core needle biopsy. And the second one is if this procedure can lead to a change in patient management. According with previous colleagues said, probably we can trust the clinical and radiological suspicion, but in our institution it is mandatory to perform an additional confirmatory test. And in this case, we decided for a core needle biopsy. Another question, well, when we performed the core needle biopsy, the results of the histology analysis documented the metastasis from breast cancer. The PET-CT documented the ani uptake in the right breast and in nomolateral axilla, but no distant metastasis. At this point, the next question is, the primary approach in a 51-year-old woman with a ductal invasive breast carcinoma, CT1C, CN1, CM0, triple negative breast cancer, may be oncoplastic breast conservative surgery and axillary lymphadenectomy, oncoplastic breast conservative surgery and target axillary dissection, mastectomy and axillary dissection, mastectomy and target axillary dissection, or primary systemic treatment.
Let's have the voting box, please. Thank you.
I think the time is complete. So 5, 4, 3, 2, 1. Now let's see the result.
I think it's pretty obvious. It's a triple negative cancer with a positive axilla, so it's a creatix effect. Most of us would go for primary stemming treatment. So what did you do, Maria Luisa?
Of course, so we did primary systemic treatment. I'm a little bit concerned about this 20% of the second choice, but it's nice since this is the aim of the meeting to obtain different opinions. So the patient underwent neoadjuvant chemotherapy with pembrolizumab and paclitaxel and carboplatin, followed by doxorubicin, cyclophosphamide every 3 weeks for 3 courses. The patient, here you can find depicted the pedigree of the patient. As you can see, here is depicted her family history. She has one case, one hunt in the father's side and grandma. And now at the point, the question is, if you recommend a multi-gene testing for breast, ovarian, pancreas cancer in our case, no, yes, based on family history, or yes, regardless the family history.
Let's see the voting box, please. 3 options, 3 potential answers. I remind you, you can move the voting box on your screen if you want. Now, this will be a long discussion because it's a different story what each system reimburses. So when the state pays for the test and when scientifically or biologically it's worth going through such a test. And most people voted yes. Right. Thodori, what do you think?
Yes, Greek state does not reimburse in her case for a genetic test, but there is an indication for a test because she's triple negative. So I would, my answer is number 3.
So here in Greece, she's not going to have this paid by the state, no, because she's above a certain age.
Exactly. Yes, and because she does not have family history of breast cancer, and she's 51. Yes, but she needs one because she's triple negative.
Konstantinos, what did you vote for?
So in the UK, anyway, in our unit in Manchester in general, women with a triple negative cancer under the age of 60, regardless of family history, do get genetic testing, and it's reimbursed.
Okay. Andreas, what do you say? Did you vote for family history testing?
No. Triple negative breast cancer is an automatic indication for genetic investigations.
Panagiotis, so it's a UK again.
Yeah, I also voted for 3 because it's a triple negative breast cancer. So according to the guidelines, she should qualify. I know that depending on the country, it's not always feasible, but that should be the recommendation.
So Giuseppe, in Italy, does the state pay for a genetic testing in this case? So 51 triple negative breast cancer with no family
51
history.
triple negative breast cancer, she will get.
She will get
tested.
okay.
Yes.
So Maria Luisa, what did you do with this case?
We agree. So these patients needs a genetic consultation and genetic test, but probably it's interesting to see that in every country there is a different indication and different governance on the topic. We trust in NCCN guidelines, and the Swiss guidelines offer this kind of test, but only in case of associated family history. And the patient underwent the genetic test, and she resulted positive for PALB2 pathogenic variant. At the radiological assessment post-primary systemic treatment, the patient underwent a mammogram, ultrasound, MRI, and PET-CT, and the imaging documented a complete radiological response in both breast and axilla. Now my question is, the type of breast surgery in case of complete radiological response in a patient 51-year-old with PALB2 mutation. What to discuss or to recommend. Breast conservative surgery and removal of the clip and clip bed. Breast conservative recommended. Recommended breast conservative surgery, removal of the entire area affected by the tumor at the diagnosis, including the clip. To discuss right mastectomy and reconstruction, to recommend right mastectomy and reconstruction, to discuss bilateral mastectomy and reconstruction, and to recommend bilateral mastectomy and reconstruction. Now we can vote.
So we have to know the differences between discuss and recommend.
Exactly. This is a very
So basically, it is a PALB2 carrier, if I remember well. So the not only carrier but patient. So we're discussing whether it is worth doing a contralateral prophylactic mastectomy in her case. Can we have the results now, please? Have we voted? Let's have the results now, please. I see. So the majority, let me group 5 and 6 together and 3 and 4 together and 1 and 2 then. So I see that there's a majority of people thinking that PALB2 genetic gene is associated with future risks of developing breast cancer, and they discussed or recommend bilateral mastectomy. Ash, what did you vote? Is Ash here?
5.
Sorry.
So I think I voted 5.
Okay. And why is that?
So if you look at PALB2 on its own, if you just look at PALB2 isolated, because we, as you know, we run a genetics clinic at Guy's, you would say the lifetime risk of an average woman is between 12 and 15% by the age of 80. If you look at PALB2 in isolation, that risk goes up to about 13 to 21% by the age of 50. But if you look at by the age of 80, that woman is an isolated PALB2 mutation without a family history. So when you have a family history, it adds to the percentage, and there's a tool you can use online. It's called CanRisk, which gives you the relative risk by the age of 50 and by the age of 80. But purely just PALB2 mutation gives you between a 40 to 60% risk of lifetime breast cancer by the age of 80.
So there is 50-50 to have, it's a 50-50 chance of having breast cancer.
That's why it's discussed, not recommend. So even with a BRCA2 mutation or BRCA1 mutation, you would never recommend a bilateral mastectomy because it doesn't save her life. This patient has a complete radiological response in the breast, so she's going to do well, provided the pathology tells us the same story. So you want to then talk to her about shared decision-making, and this is where I think Giuseppe will do a better job than me, about discussing the various options. That's why I take discuss and not recommend. You have to give the patient enough information for her to make an informed decision. It is your duty as a surgeon. You don't have to recommend, because we know that there is data. If a surgeon recommends certain surgery, including contralateral prophylactic mastectomy in non-high-risk carriers, they will go ahead and do that. So as long as we are concerned, or I'm concerned, I will provide data and I will provide risks and benefits of both. And then the patient will make the choice on a bilateral mastectomy. Doing breast conservation in this patient is also not wrong, because we have students online, so they need to understand there is no wrong option here. It is what you explain to the patient and what she chooses.
So you're saying basically that this patient has higher risk of developing breast cancer in the future, but we're not certain whether removing both breasts will increase, she will benefit as a survival, in survival terms. Is that right?
Absolutely right. And this goes for all gene mutation carriers.
I have a feeling, I don't know why, that Andreas has voted for a lumpectomy.
No, so I did not vote for a lumpectomy. I am in favor of discussing mastectomies in this setting. Just to corroborate on what Ash discussed, I will just put another piece of evidence in the discussion. So I will refer you to the latest publications from the Carriers Consortium, which was presented in San Antonio in
Last
December
year.
2022. Yes, and
Yeah.
has been published at Journal of Clinical Oncology. So in this study, the authors found that there is significant risk of contralateral breast cancer and higher risk for in-breast cancer recurrence in PALB2 mutation carriers with an ER-negative index cancer.
Exactly. So it's about ER negative.
Exactly. So this is one more key in the discussion. We can be all in agreement in terms of that we do not expect to increase survival by just offering more surgery. We know that survival benefits exists only in the risk reduction setting for BRCA1 mutations in premenopausal women that have removed their ovaries first. This is the most definitive evidence that we've got. Our risk here is the PALB2 mutation, the ER-negative breast cancer. And if one is a little bit more interested and looks into the supplementary material of this publication, but the New England Journal of Medicine publication from the Carriers some years ago, you will see that these patients do have a higher relative risk of a second ER-negative breast cancer, which means that motivating surgery, bilateral surgery in this context, may be beneficial in the sense that they will avoid chemo, a new adventure with chemo.
New chemo.
Okay.
So Giuseppe, let me take the Italian aspect of things. What would you do?
Well, I voted for discuss bilateral mastectomy, obviously, and I will discuss with the patient the possibility of having the chance to survive with her breast. That means less toxicity, better quality of life, but still, I mean, if she is able to cope with the risk of subsequent cancer and the risk of having chemotherapy later, and she's happy with this, I will give her breast conservation. Especially, I mean, in this case, having a good response means that she will survive to the diagnosis, so she will be exposed to cancer. But anyway, I want to discuss with the patient all the details of having a bilateral mastectomy and having breast conservation, and I will support her decision.
Yannis Natsiopoulos.
Thank you, Michalis. I voted, of course, the file, but in any case, we have make clear something to the patient, that it's a different issue, the treatment of current disease and the prevention of a future disease. Because many times patients think that the bilateral mastectomy affects the outcome of the current disease. We have to clear it out in every patient.
Well, thank you. I'm so glad to hear that it's not only overall survival, the only drive for our decisions. It's other things as well. So going back to Maria Luisa, what did you do with this case?
Okay, so based on all the correct comments we shared before, and as you can see depicted the results that have been mentioned before, we discussed the bilateral mastectomy. Since our patient was in premenopause, she was affected by an HER-negative disease, and so the significance is here reported, and we decided to discuss with the patient, and the patient decided to undergo bilateral mastectomy. Now, at this point, the surgical decision is regarding the axilla. So the radiological assessment after neoadjuvant chemotherapy documented a complete radiological response also in the axilla. And the question is, again, which kind of axillary staging offer these patients in case of conversion from node positive to node negative? Omission of the axillary staging, sentinel lymph node biopsy, triple negative, target lymph node biopsy, target axillary dissection, or axillary dissection. Probably the best way in order to formulate this question is what you do, since probably more than one question answer is correct, but what you currently do.
That's right. Let's see. So what would you do in that case? Let's see the answers, the potential answers. Vote now, please.
So 5, 4, 3, 2, 1. Now let's see the results.
Okay. We like playing with clips and markers, apparently. So the vast majority of people voted for targeted axillary dissection. Is there anybody who voted for sentinel node biopsy only? No. Okay. So I think it's worth moving on directly to the next slide. I just want to say that there's no still hard evidence for or against sentinel node biopsy versus targeted axillary dissection. In these cases, we're expecting the Axana and other trials results. So what did you do, Maria Luisa?
Okay, we recruited the patient in the Axana trial. As you previously said, we don't know yet which treatment works better, but we performed a target axillary dissection. So the patient underwent both the procedure, the lymph node targeting through a bar guide and the lymphoscintigraphy. Now the question is, in case of target axillary dissection or planning of a target axillary dissection, the optional timing for the lymph node marking is at the time of the core needle biopsy of the breast lesion, at the time of the core needle biopsy of the lymph node biopsy and marking in the same procedure, or in a second procedure after receiving the confirm of the axillary involvement from the pathology. Now we can vote.
The question is when you put the marker in the node. 2 clinic visits or 1 clinic visit? Vote, please.
So 5, 4, 3, 2, 1. Let's see the result.
Right. So most people thought that it is practical to put a clip in the node at the same clinic visit as the biopsy of the node. It saves the patient a clinic visit because we trust our ultrasound scan that the node is positive. Anybody voted for any other option, bringing the patient back to the clinic for just a clip placement? Panagiotis, what did you do in your hospital?
So it's placed at the same time as the biopsy in the lymph node. So the radiologists take a biopsy from the lymph node, which is suspicious, and at the same time they insert a marker so that it's ready in case it needs neoadjuvant treatment.
So for clip, what do you think? What would you do in this case? Is it same clinic visit, another clinic visit?
I think it depends on the case. I don't know if you have a lymph node with a 3.5 millimeter cortex and it's 8 millimeter as a lymph node, you are less confident that this one will be positive than other lymph nodes. If you have a 3 centimeter lymph node, of course, you know that this is one. You take core biopsy, you put a marker, that's okay. But what about those cases, the borderline cases that you get negative axilla and you get an ultrasound and searching a lot, you find a little bit of a thickened cortex? I don't know.
But
sometimes I'm getting clip
even
in.
these cases, so even these, I agree with you, it has to go by the case. And I'm reminding you that Axana accepts patient with positive nodes without cytological or histopathological confirmation of the node positivity. So it based only on the radiology. But again, you might want to remove an ambiguous node in your surgical procedure. So you might want to clip it. But I agree, it has to go by the case. It has to go by the case. So what did you do, Maria Luisa?
We did it in the same procedure, but now the further question is how many suspicious nodes should be marked? Probably we already discussed something about it in the previous case. only one, the most representative, from 1 to 3, or all suspicious nodes. We can see if now something is changes after the discussion.
So I hope that we have an unanimous answer after all this discussion. Yes. Okay, let's see the results now, please. Okay, I think that's a great majority. The vast majority of people think that marking the one node is enough. What did you do in this case?
But it is we agree, but in reality, worldwide there is no agreement at the moment. When we published the survey you mentioned before that we co-authored, there is a worldwide unclear opinion about that. When we asked the countries, the representative of the countries, if confirmation of metastasis by histology or cytology is recommended, there is no consensus, as you can see in the first picture on the left side. The same when we ask the breast surgeons, how many nodes do you routinely mark in case of several suspicious nodes? In case of multiple suspicious nodes, 65% of the breast surgeons declared to mark only one node. It means that significant part of colleagues do not do that. Okay, now we arrived in the operative room, and at this point, the clip that we put with an additional marker was not found in the removed lymph node. And since we planned to perform a target axillary dissection, we didn't use dual tracer, and we found only one sentinel lymph, so no free lymph nodes when we tried to make the procedure. And so my question at this point is, axillary staging in clinically node, or better to say, in patients who convert from positive to negative clinical node post primary systemic treatment with not feasible target axillary dissection due to intraoperative finding of lost marker and only one lymph node detected by technetium after lymphoscintigraphy, which is the most appropriate treatment you want to offer these patients? Axillary lymphadenectomy, lymph node sampling, histology analysis of the only sentinel lymph node you retrieved.
Let's see the voting box, please, now.
Five, 4, 3, 2, 1. Okay, let's see the result, please.
Oh, God. Right. So basically, this result says that we don't know what to do. And it goes with the photograph with that person on in the middle of nowhere in the sea. I see. Let's start with Giuseppe.
Well, I don't think that doing an axillary section in this case is a critical decision. You can do it. I mean, if you do a very good axillary section, if you preserve the nerves, you will get the right information. I mean, it's not a critical issue, really. Okay, if you can save the axilla, it's much better, we know. But in this case, you don't want to miss any false positive. And I don't think that we have sufficient data for approving a lymph nodal sampling that could give you still false negative lymph nodes.
I see Andreas agreeing.
Yes, so just mostly to lift that for the trainees. So with the absence of data that suggests otherwise, I am not aware of any country in which is practice you have medical legal support to do anything else than an axillary clearance in this setting. Okay, you can throw it on the discussion with the patient, you can throw it at the MDT, you can discuss whatever, but formally, where we are now, we need to have adequate axillary staging. And I just need to remind here that nodal status post-neoadjuvant chemotherapy is a stronger prognosticator than local status in the breast. So keep that in mind, because we are discussing about de-escalation, but the point is always to get right and adequate information. It is not to de-escalate just to de-escalate. We need to rationally de-escalate, and you should not demonize an axillary clearance. It is, as Giuseppe said, this is not a critical decision.
Means
Okay,
that
so-
all the time, I'm sorry.
No, go on.
No, it means that all the time we have only 1 or 2 lymph nodes with a sentinel lymph. When sentinel lymph node biopsy is planned after neoadjuvant chemotherapy, you recommend to perform an axillary dissection.
No, I did not say that. I said that. So, if we have to discuss about formalities, so I'm thinking what would fly in a patient complaint case, for example. TAD is formally defined and discussed as the procedure in which you remove the index node, the node that you knew had been metastatic, followed by dual tracer-based sentinel lymph node biopsy. That's the case. So since we had single tracer and localization failure, then you depend only on the 3 as a magic number, because both the Sentina, the Z1071, all these studies showed that, especially the Zeta1071, showed that the clip node will reduce the false negative rate, but it is the number 3 that is more important in their multivariable analysis. I'm not suggesting that we should be striving for 3 no matter what, or we should clear if we do not get 3. I'm just saying that the patient needs to be aware of that beforehand, and we cannot, in this particular case, depend on a single node.
Is anybody aware? Sorry. No, go ahead, Maria. Go ahead.
No, the last thing. Since if we assume that TAD and sentinel lymph node biopsy are equivalent in this setting, I think that if we perform an accurate counseling prior to the procedure, we can treat this patient as for sentinel lymph node biopsy.
Yes, under the assumption that they work equally well. The problem is that if you look at the data, there is the meta-analysis from the Irish group on British Journal of Surgery a couple of months ago that suggests that once you have a complete axillary pathologic response, everything works well regardless of what you have done, but this is highly dependent on the false negative rate. So in this meta-analysis, they did not take in consideration axilla that were understaged according to the current criteria. That's the one thing. The other thing is that if we go back and look at Mario Schmidt's group meta-analysis on annals of surgery, targeted axillary dissection with the definition I gave has significantly lower false negative than sentinel lymph node biopsy. So this is a gray zone area, but the way things look like now, and now I'm putting on my editorial hat and my medical advisor hat, but to put it plainly, if something went wrong with something like that, that would not fly in court, so to say.
I agree with the court and the medical legal issues. I want to ask the panel, is anybody aware of the very recent publication by Galimberti about from Milan about the which reports that 10-year follow-up of these patients without a targeted dissection, but treated only with sentinel node biopsy, is no inferior to clearance.
Yes, of course, but this pertains to the patients that had a complete pathologic response on sentinel lymph node biopsy only. That's the issue there, and they did not stratify by the number of nodes. I don't think that they consider ACEs in that.
No, they didn't, but they did not try to remove 3 or more nodes.
No, they did not. But the thing is that you have to make you have to make the case for that, because the subgroup with 1 node removed was the minority here. So you cannot just extrapolate on that.
Okay, Ash, one quick, say something quickly because we have to move on.
Okay, so I think what Andreas is saying and what everyone is missing is this is a single tracer. So you've used a single modality to find a lymph node. You've not only found 1 lymph node, you've also missed the targeted lymph node. If you compare a sentinel lymph node biopsy to a targeted axillary dissection, and I know Galimberti's paper, but you look at the Memorial Sloan Kettering, which is Monica Morrow, she does not clip the node, but she retrieves 4 nodes. And the data from MSKCC clearly says if you retrieve 3 to 4 nodes, it is equivalent to a targeted axillary dissection or a clip node. And as we know from all the trials, you require at least 3 nodes to reduce your false negative rate. And the important part here is standard of care is still an ALND in these patients. The people who are doing TAD and doing sentinel node biopsy are actually going a little off piste based on the data that they've got. But none of these trials that we are talking about, the Z1071, the Sentina, they were all feasibility studies. Now you've got Galabretti's paper and MSKCC that's saying that there is no difference in survival. But if you look at standard of care, it's still axillary clearance. So in this patient, if you missed the boat of a targeted axillary dissection, you have to go back to standard of care, which is an ALND.
All right. Maria Luisa, what did you do with this case?
Okay. I just wanted to be provocative, and it was successful.
It was indeed.
So we sent to intraoperative analysis the lymph node we were able to retrieve, and the intraoperative analysis documented micrometastasis in the lymph node we removed. How to complete the axillary management in case of micrometastasis after primary systemic treatment? No further axillary intervention, post-operative regional nodal irradiation, axillary lymphadenectomy, or a combination of axillary lymphadenectomy and regional nodal irradiation. Now we can vote. Okay. We still have 5.
It is 3 options, not 4. 3 options.
No, probably
4 options. It's 4 options. 4 options.
I can't see the 4th one.
There are 4 options too.
Okay, sorry.
Last one is axillary lymph node dissection, regional radiotherapy. The 4th.
Okay, now let's see the results.
So most of us voted for axillary node clearance and regional node irradiation. Sorry. So, Konstantinos, what did you do? What did you vote?
How many nodes were positive initially?
We tell you now 23. 1 positive node on 23 lymph nodes removed.
Okay. Okay. After the clearance. So no, I voted initially clearance and wait and see the result from the clearance to see.
Yes, I'm sorry.
But my question was how many nodes were positive before surgery, radiologically, before chemo?
2.
2.
But only 1 was biopsied.
Well, yeah, axillary lymph node clearance would be my surgical step, and then followed up by radiotherapy. It's something I think that would be offered to the patient based on the pre-chemotherapy result with at least 2 nodes radiologically positive.
Dr. Dimopoulos, what do you think?
Yeah, I have the same opinion. So again, I would go for axillary lymph node dissection and afterwards regional nodal irradiation, since we had one disease at the beginning. So it's the same as we had, the same situation we had in the first case. So in case of having the conversion of N1 to N0 disease, I would go for radiation.
And what are the fields of radiotherapy exactly?
What are the fields? So in that case, so as far as I understood, axillary lymph node dissection was performed. So in this case, the patient would receive irradiation to the supra and intraclavicular region, and then as well to the chest wall.
Okay, then. So what did you do, Maria Luisa?
We performed an axillary lymphadenectomy, and also in this case, we investigated what's the current clinical practice. This paper is not published yet, but it's snapshot on what is happening at the moment. And as you can see, we compare the responses from breast surgeons and radiation oncologists. These responses do not fit Very well. So probably there is not an agreement yet between these two specialists. We underwent, as previously said, I'm sorry, I anticipated an axillary lymphadenectomy. And the final pathology documented a complete response in the primary tumor and micrometastasis in the only one lymph node we sent for the present section. It was confirmed also at the definitive analysis. Now the question is, adjuvant therapy in triple-negative breast cancer with complete response in the primary tumor, but minimal residual disease in 1/23 lymph nodes removed, is an indication for capecitabine, or it can be omitted. So answer yes, it can be omitted given the minimal residual disease after primary systemic treatment. And the answer 2 is that it should be offered regardless the tumor burden. We can vote. We can probably show the result.
Let's see the results now, please. Okay. So Elias, what do you think? Micrometastasis, only residual disease in the node, capecitabine or not?
First of all, I'd like to ask, why not Pembro?
Yeah, Pembro, of course. Pembro is considered standard in this case. So, I mean, in addition to Pembro, capecitabine, yes or no? So Pembro was administered in the neoadjuvant chemotherapy, and it will be continued also in the adjuvant setting. I'm sorry, I didn't specify, but it was considered a standard of care.
I think
so. Let me put it straight. So the protocol, Maria Luisa, is that you give Pembro anyway, and you ask whether capecitabine should
in
given as well. Okay.
Exactly. Since data on metastatic patients didn't show any or potential risk of the combination, and so in Switzerland we do offer, I don't know as where exactly, but in Switzerland we do offer both treatments in combination. But my question is, in this case, since we are in a borderline situation, should we offer capecitabine, yes or no? In addition,
yes, I totally agree with you. There's safety data in the metastatic setting, so there's no added toxicity here. And taking into account the poor outcome of this patient, I think it's very reasonable now to consider a combination of these two drugs.
So what did you do, Maria Luisa?
we gave the patient capecitabine in addition to pembrolizumab.
Good.
Now there is one new. When we performed the axial CT scan prior radiation therapy, we found the axillary lymph node clip remaining after surgery. The one we didn't found during the surgery. Now the question is how to manage the remaining marker in the axilla. A second surgery should be planned to retrieve the lost marker. Modified postoperative indication in case, for example, radiation therapy was not planned. On strict follow-up every 3 months for the next 3 years, or it doesn't matter, regular follow-up. We can vote. Okay, so 5, 4, 3, 2, 1. Let's see the result.
So most people voted that it doesn't matter if there's a marker left in the axilla. Giuseppe, you agree with that? Is it okay to leave a marker in the axilla? We left a marker in the axilla somewhere. We didn't manage to retrieve it. Is it okay to leave it there, or we should go for it and reoperate the patient?
My understanding is that we have a lymph node with the marker in the axilla, not only the marker. If it's only the marker, I don't care. But if there is a lymph node, I will suggest follow-up. I don't care too. I mean, Is it only
just
the
follow up,
marker?
normal follow-up.
Sorry, once again, is it only the marker? Because I'm reading here, right axillary lymph node clip. So it's only the marker, not the lymph node.
Yes, it's only the marker identified, but at
I
the
don't care.
CT scan, exactly.
Change is just regular follow-up.
Okay. There's one and on and up.
Yannis Natsiopoulos wants to say something.
Yes, I have to make a comment. We should try to retrieve the market during the surgery. We could use a portable radiological device, a CR device, that finds out if there is a remaining clip into the axilla, because sometimes we remove the clip, but in transferring the specimen to the pathological laboratory, sometimes dislocated. So we could try to find out if there is a remaining marker with a remaining lymph node during first surgery using a portable radiological device. It works. But anyway, it doesn't matter if we leave the marker into the axilla, because there is no additional decision to make about treatment of the patient.
So what did you do then?
I voted the 4.
4. Okay. So what happened to this patient?
The 4 regular follow-up, and based on the preliminary results of the external trial, we found that the target axillary dissection is adopted mostly from German-speaking countries. I mean, Austria, German, and the German canton of Switzerland. This is why I decided to take the AGO guidelines, and since these are the countries with major experience in TAD, they recommend an axillary lymphadenectomy, as previously said by the colleagues, when the marker cannot be identified, but no further invasive procedure to retrieve the lost marker.
Right.
And the last interesting point to discuss is that this is not our patient, this is a case report, but sometimes it is possible to identify the clip dislocated, and at the same time, if we have a good pathologist, we can see the clip bed in the lymph node that was removed. So I would like to thank you all, and I also thank my colleagues that work with me and collaborating in the managing of this patient. Thank you.
Well, thank you, Maria Luisa. That was an interesting case with lots of questions. You raised every problem we may ever face. Thank you for that. And we have managed to be only 1 hour late. So Sophocles, what do you think we should do? Have a break?
I think we should move on and have the 2, because they're quite interesting, the 2 pre-recorded lectures we have about the genetic signatures. And we also need a break. We all need a break. So I think we should carry on with the pre-recorded lectures, and we'll be back for part 2 at 2:10, which is going to be almost an hour late. But I think it was quite interesting what we got by now, and I think we have some time to kill in the end of the session. So, Michalis, would you like to talk about these 2 pre-recorded lectures before we carry on?
Well, it's 2 pre-recorded lectures, but 2 of our sponsors. The one is from Gene Analysis and Myriad, another is GeneCore, and they are both, I highly recommend you watching this, and they can start right now.
And we'll be back for part 2 in about 10 minutes after 2. Okay?
2:10. Thank you.
Good evening. My name is Nicholas Choulos, and I'm very happy and honored to be part of this very interesting webinar on breast cancer. And I'm here to talk to you today about the multi-gene assays, to go over the clinical guidelines and the prospective clinical trials and what are recommended for the usage. of such assays in management of early stage breast cancer. So what I'm going to go over is the unmet need of personalizing treatment of patients that are hormone receptor positive, HER2 negative, early breast cancer, go over the data of the Oncotype DX recurrence score test, go over the clinical evidence of the test, and also summarize and go over a case presentation. So the reason why we're here discussing about the multi-gene assays is the fact that there was an unmet need in personalizing the treatment of early stage breast cancer patients. And the question is, who do we treat? And the question emerges from the fact that no matter what treatment you see in early stage breast cancer, when it comes to chemotherapy, you see that the benefit, either when we're talking about breast cancer recurrence or even the mortality of breast cancer, never exceeds 10%. So what we're trying to identify is within this absolute benefit, who are the 10 patients that do benefit from chemotherapy and who are the 90 that do not. So our target is to be able to separate those two populations. And in order to do this, we need a robust tool that has also both prognostic and predictive information to share. So what we're trying to eliminate is within the high risk populations clinically to be able to identify the patients that do not benefit from chemotherapy. And on the other side, among the low risk, clinically low risk patients, to identify those patients that actually benefit from the addition of chemotherapy. I'm going to go over the data of Oncotype DX. So the Oncotype DX test is based on a 21 gene assay. We have 16 cancer-related genes and 5 reference genes. And you see that the cancer-related genes are based on the estrogen group, the proliferation group, the HER2 group, in which you see genes that we are very familiar with, like the ER and the PR genes, the Ki67, the HER2, but many others as well, and also the invasion group. At the same time, these are referenced against the reference genes, which are there to normalize the tissue, and all these combined in an algorithm produce the recurrence score, which is a score between 0 and 100. Initially, the importance of the test is based on many validation trials, and I'm going to go over the important ones. So in order to validate the prognostic value of the test, we analyzed the samples from the NSABP14 trial for the node-negative patients and the patients from the TransAttack trial for the node-positive disease. But that's not the core of the test, because that was just half the picture. The rest of the information, which is even more important, is the predictive value of the test. So we were trying to show whether the test can identify patients that have chemotherapy benefit. In order to do this, we analyzed the patients from the NSABP20 trial for the node-negative patients and the SWOG8814 trial for the node-positive disease. And of course, since it's a necessity to have prospective randomized trials, the TAILOR-X trial was designed for the node-negative patients, and the RxPonder trial was designed and executed for the N1 population, as we will go over shortly. So for the clinical validation of prognosis, as I said, we used a landmark trial, the NSABP-B14 trial, which is the trial that brought to the lives of patients, of breast cancer patients, tamoxifen and endocrine therapy in general. So this trial, just to remind you, randomized patients between placebo and tamoxifen. All these were ER-positive, node-negative patients. And what was initially done for the Oncotype DX test was that the tamoxifen arm was utilized in order to be able to show if we can identify the high risk versus the low risk populations. And of course, that was performed and was very successfully conducted, because the patients with a low recurrence score had a very good prognosis, in contrast with the patients with a high recurrence score that had a very poor prognosis. And you see that this was strongly statistically significant, and the p-value was very strong, less than 0.001. Now, of course, as I said, that was not enough, because we had to give the other half of the picture for the patients, which is, do they benefit from chemotherapy? And just knowing the prognosis, you cannot assume that. So the B20 trial was the trial that brought chemotherapy to the lives of patients, of early stage breast cancer patients. Again, ER positive, node negative patients, randomized between receiving chemotherapy, tamoxifen and chemotherapy, or just tamoxifen alone. And what we did is we analyzed those samples for with Oncotype DX, and we were able to stratify the patients based on the chemotherapy benefit, which means that every patient below the score of 25 had no chemotherapy benefit, as you see here among the gray and the pink lines between them. But you see that the patients that had a high recurrence score over 26, those patients had a 26% absolute chemotherapy benefit, which is rare. We rarely see in oncology such a big benefit. So conclusion from this was that we were able predictively to show who benefits and who does not benefit from the addition of chemotherapy. And of course, in order to validate all this, and in order to show that in the in-between zone, which is between 11 and 25, there's no patients that actually show any chemotherapy benefit. So we were trying to show whether the addition of chemotherapy was superior to just endocrine therapy alone. So this is TAILOR-X was designed prospectively with 10,000 patients, looking at whether chemotherapy is a non-inferiority trial. So we're trying to show if endocrine therapy alone was inferior to the addition of chemotherapy. And as a conclusion from this trial, we showed that there's no chemotherapy benefit in that population. So these patients were randomized between receiving chemo and no chemo, and they with a score of 11 to 25. Everybody below the score of 11, so from 0 to 10, they only took endocrine therapy because we had strong data from the B14 and B20 trial that these patients do not benefit from the addition of chemotherapy. On the other end, everybody with a score over 26, they were clearly validated that they actually benefit from chemotherapy, and they all received chemotherapy. So in that score between 11 to 25, there was no benefit from chemotherapy in the from the TAILOR-X trial, and this was with a median follow-up of 7.5 years. Even if we looked at different endpoints like the DRFI or the overall survival, you see that there's no chemotherapy benefit in any one of the endpoints. And also there's no subgroup that actually benefits from chemotherapy besides the subgroup of the age. So even if they had a high grade versus low, or a bigger tumor versus a smaller tumor, or a clinical risk high versus low, there's no chemotherapy benefit. The only place where we saw some chemotherapy benefit was the patients below the age of 50. And we will go into this a little bit more. This population, which was this benefit is concentrated in the population between 40 and 50 years old, which shows us that most likely it has to do with the ovarian function suppression effect of the chemotherapy and not actual chemotherapy directly benefit. But because we don't show this, and we don't see this, excuse me, in the patients below the age of 40, where OFS is more rare. But we'll get back to this after we go through the node positive data as well. Last December, in San Antonio, in the Congress of San Antonio, the updated analysis of the data from the TAILOR-X study were announced and presented. And now we are looking at 11 years follow-up versus the 7.5 years median follow-up that we had before. In the updated analysis, we see that the subgroups, the low versus high, maintain their strong statistical significance in difference. So this stratification remains over time of low versus high. And also the patients with scores between 11 and 25, in all the endpoints, they never showed any difference more than 1%, exactly as they were in the initial 7.5 year time frame that we had the initial follow-up of the study. So this shows also in late recurrences that the data from the test are reliable throughout the this time frame, and we're of course continuing to follow up since the test is the trial, excuse me, is designed to have a 20-year follow-up. So we will be following up these patients over time. But for the 11 years median and average 12-year follow-up that we have now, it's very clearly that the low-risk patients remain low risk, and there's no chemo benefit even in that time frame. So late recurrences are also taken into consideration. And as you see here, between the primary analysis and the updated analysis, in all the endpoints, as I just mentioned, there's no statistical significance, and it's always less than 1%, the difference. When we're looking at that subgroup of the 50 years old group that we mentioned before, you see that from 11 to 25, even in the updated analysis, there's no chemotherapy benefit, and there's a marginal benefit from the scores of 16 to 20, which is located, it's identified only in the high clinical risk patients, so patients with a higher grade and a higher size, and everybody over the score of 21 has a substantial evident chemotherapy benefit, which is approximately 8.5%. So you see clearly that this data is very similar to the data that we had from the initial trial. So very confidently, we can say that we're treating the patients the right way based on this test. And we see again that this age group is limited to patients between 40 and 50, and menopausal status is not relevant. So we see it only in the age limit, not the menopausal status limit. And we don't see it in the patients below the age of 40, which shows that most likely it has to do with the ovarian function suppression and not with the actual chemotherapy benefit. But we'll get back to this when we go over the node-positive disease as well. So as a conclusion, as I said, summarizing the node negative, we have data in all the subgroups. We have prospective data from the patients in between 11 and 25. We have long follow-up, so we can confidently cover also the late recurrences. And there's no practical changes in any endpoint in this subgroup. But focusing now on the node-positive disease, initially trying to show the prognosis, we used this landmark trial, the TransAttack trial, which is the trial that brought aromatase inhibitors into patients' lives. And Oncotype was utilized in order to show if we can identify who's at low risk and who's at high risk based on their gene signature. And of course, this was done in a very strongly statistical way, and having patients with a low recurrence score had a very much lower prognosis, lower risk and better prognosis compared to the patient with a high recurrence score, where they had a high risk and a poorer prognosis. And I remind you that these patients are N1 disease, so it's 1 to 3 positive lymph nodes. And of course, that was the prognostic part, so half the picture. The other half of the picture is the predictive part, and we found, we worked with the SWOG team for the SWOG 8814 trial, and these were N1 patients mainly, but there are also patients with N2 disease in this group, and we were they were randomized between getting chemo and no chemo, which is ideal for showing prediction chemotherapy benefit. That's actually the only way to show chemotherapy benefit. So we analyzed the samples, and we showed that the patients in the low recurrence scores had no chemotherapy benefit at all, and the patients in the high recurrence scores had a high chemotherapy benefit, which was statistically significant as well. And this separation started at the score of 25 and above. The curves were able to separate at that point, as you see here. So our Exponder was a trial that was designed prospectively in order to validate this data. And what was done is that patients below the score of 25, N1 disease, ER positive, HER2 negative, were all of 5,000 patients had scores between 0 to 25. The whole study had almost over 9,000 patients. So 5,000 of them were with scores between 0 to 25, randomized between endocrine therapy alone and chemotherapy followed by endocrine therapy. And everybody over 26 clearly benefited from chemotherapy from the SWOG trial. So those were, they took the path of chemotherapy. So in December of 2020 at San Antonio, the first data was introduced, were actually presented, and we had a 5.1-year follow-up. And then next year at the New England Journal of Medicine, there was the 5.3-year follow-up, and that was published. And the same year in San Antonio was also 6.1 years data presented. So this is the diagram to show you the inclusion criteria and the evaluation of the patients and the exclusion of some patients. And here's to show that between the two arms, the trial was balanced between the endocrine arm and the chemoendocrine arm. And the results were as expected, that there's no chemotherapy benefit overall in that group in scores between 0 to 25. So the trial successfully showed that patients with a score below 25 do not benefit from chemotherapy in the invasive disease-free survival, distant recurrence-free survival, and every endpoint we showed the same. When we separated based on menopausal status, we saw that in the postmenopausal patients, this was strong. The data was showing that there's no chemotherapy benefit. And there was no subgroups among the postmenopausal patients that actually had the benefit from chemotherapy, regardless of age, grade, size, clinical risk, even number of lymph nodes, 1 versus 3 or 2 versus 3, even if the recurrence score was below 13 or from 14 to 25, or even the histological subtypes. Nobody showed in that group between 0 to 25 recurrence score that there's a benefit of chemotherapy. So we safely forgo chemotherapy for those patients. On the other side, in the younger premenopausal patients, we saw some benefit of chemotherapy in all the endpoints. And that was clear in the distant recurrence-free interval, which we had 2.5% chemotherapy benefit, and the invasive disease-free survival, that was almost a 5% chemotherapy benefit. And in all endpoints, it was the same throughout in the younger premenopausal population. So you see here that all the subgroups, in contrast with the postmenopausal, here all the subgroups had benefit from chemotherapy. So even if it was 1 lymph node versus 2 or 3, or high versus low clinical risk, everybody had benefit from chemotherapy, regardless of age. As long as they were premenopausal, they had benefit from chemotherapy. So for the node positive patients, the cut point is menopause, in contrast with the node negative patients, where the cut point is the age. And even when we looked at micromets versus N1 disease, we saw that even in the micromets, if they're premenopausal patients, those patients benefit from chemotherapy. And this most likely, as I said, is related to the menopause, because the patient that had initially had their periods, and then from the premenopausal, and then they lost their periods, then you saw that those patients had a smaller probability of IDFS, which is the purple line on your screens, and the same is both on the endocrine side and the chemo side on the right. So because we saw this effect both in the node negative patients and the node positive patients, a new trial is actually being launched currently, the OFFSET trial, which it's premenopausal patients that are ER positive, HER2 negative, N0 or N1. And these patients are all oncotyped and stratified. And if they have a score below 25, they're randomized between OFS and aromatase inhibitors for 5 years, or chemotherapy and OFS and aromatase inhibitors for 5 years. And this will answer to us the question of whether this effect that we see is based on chemotherapy or on the OFS. So just to put everything in a nutshell, when we have HER2 positive, HER2 negative, estrogen receptor positive, early stage breast cancer, and we have a node positive patient with a score below 25, then if this patient is over the age of 50, then endocrine therapy is clearly the way to go. This is non-inferior to adding chemotherapy. If this patient is younger than 50 years old, then we see some benefit in the scores between 16 to 25, including incorporating also the clinical risk as we discussed. If there's a patient with N1 disease with a score below 25, if they're postmenopausal, then they have no chemotherapy benefit. If they're premenopausal, as we said, then you see a 2.4% benefit in 5 years on the distant recurrence-free interval with the chemotherapy. So there is chemotherapy benefit, 2.5%. And then On the other side, even if it's a node N0 or N1 disease, if the recurrence score is over 25, then there is an increased chemotherapy benefit. And this is what is shown in all the guidelines. The ASCO, as I will show you in the example as we go over it, the ASCO guidelines in the CCN have it as a preferred test that with the highest quality, and then St. Gallen and ESMO are also mentioning this as the decision maker for chemotherapy in those patient populations. So just to
Hello, my name is Claire Jackson. I am the Clinical Affairs Manager for Myriad International. Thank you for the opportunity today to present the most recent evidence for the gene expression test EndoPredict. My presentation will briefly cover an overview of the test, followed by the new prospective data, highlighting the consistency of results for EndoPredict and confirming that previously seen in the validation studies. EndoPredict is a second-generation gene expression test developed specifically for the ER-positive, HER2-negative, node-negative and positive target population. Tumour gene expression is calculated and reported as a 12-gene molecular score, sometimes referred to as the EP score. This is then combined with the clinical parameters tumour size and nodal status to produce the EP-Clin risk score. The EP-Clin risk score is reported as a binary high-risk, low-risk result with only one cutoff to consider, predicting both early and late recurrence out to 15 years. It is important to note that EndoPredict is run locally and reimbursed in Greece. This ability to run EndoPredict locally in-country is something that was recently highlighted within the ASCO guidelines publication. The EndoPredict report is a multi-page report providing 3 pieces of information individualized for the patient to aid in treatment decisions. An example of the first page is shown here for both a low-risk patient in green and high-risk in blue. The summary at the top details the patient's clinical information, EP-Clin risk score, and EP-Clin risk class. The bottom section summarizes the 3 pieces of individualized information and is organized by treatment planning stage. What's the risk of recurrence in the next 10 years? Can the patient avoid chemotherapy? What is the absolute benefit from chemotherapy? And what's the risk of recurrence years 5 to 15 after 5 years of endocrine therapy without recurrence? Can she safely avoid extended endocrine therapy? The detail for these is then provided on the subsequent pages of the report. This slide provides an overview of the training validation roadmap for EndoPredict. The key point to take from this table is that EndoPredict has been validated in 6 independent prospective retrospective studies in over 5,000 patients with ER-positive, HER2-negative breast cancer. The aim of the 6 studies was to show that the test could predict distant recurrence and significantly add information to standard clinical pathological factors. By combining the 12-gene molecular score with nodal status and tumour size, in all studies, the EP-Clin risk score consistently identified breast cancer patients with very low risk of death for 10-year distant recurrence, ranging from 0 to 5.8%. With 6 prospectively designed independent clinical validations, these studies together form level of evidence 1B, further confirmed by a prospective study with level of evidence 1A. One component I would like to highlight is the selection of tumour size and nodal status as the clinical features included in the EndoPredict result. In one of the early validation studies, the relation between EndoPredict 12-gene molecular score and distant recurrence was assessed by Cox models adjusted for the variables shown on the table. In both data sets, the only independent predictors of distant recurrence were tumour size, nodal status, and the 12-gene molecular score, the 3 variables which make up the EP-Clin risk score. It is important to note that age and, as I'll show later, menopausal status are not prognostic of outcome. And now to the 2 most recent data. We have 2 prospective studies presented at the 2022 San Antonio Breast Congress. The first study, an independent prospective registry at TUM Germany, provides the first prospective outcome results for patients whose adjuvant systemic therapy recommendation was based on the EndoPredict test result. 368 women with HR positive, HER2 negative, node negative, and node positive early breast cancer were enrolled in the routine clinical setting between 2012 and 2015. Therapy recommendations were made by an interdisciplinary tumour board. The median follow-up was 8.2 years, and the key patient characteristics are as shown on slide. Of the 368 consecutive cases included, 2/3 were classified as EP-Clin low risk. The analysis showed EP-Clin high-risk patients had only 85% distant metastases-free survival at 5 years, demonstrating they were at significantly greater risk than those patients with EP-Clin low risk. This significant difference between the low and high-risk groups demonstrates the ability of EndoPredict to accurately identify those patients with low risk of relapse who might avoid chemotherapy, confirming that seen in our previous prospective retrospective validation studies. If we then look at the same distant metastases-free survival results by menopausal status, 1/3 of the study population were premenopausal and 2/3 postmenopausal, with 63% and 65% classified as low risk as shown. In both the pre- and postmenopausal subgroups, patients with an EP-Clin high-risk result, as shown in blue, were again at significantly greater risk of experiencing distant metastases compared to those with an EP-Clin low risk, shown in green. This demonstrates the ability of EndoPredict to identify patients who may safely avoid chemotherapy regardless of menopausal status. And this prospective analysis confirms the results of the recently published premenopausal study from Cyprus in UK, which I will show later in the presentation. And finally, analysis of EP-Clin high-risk patients by the treatment they received. Of the 130 patients classified by EndoPredict as high risk, 2/3 received chemotherapy while 1/3 declined. The graph on slide shows the rate of disease-free survival according to treatment received. Patients who received chemotherapy, shown here by the dark blue line, had a significant benefit at 5 years versus those who chose not to receive chemotherapy. Almost 90% of patients were disease-free at 5 years versus only 70% of the non-chemo group. The authors concluded that patients categorized as EP-Clin high risk benefited from adjuvant chemotherapy. And this prediction of chemotherapy benefit in a prospective study confirms that seen in the retrospective comparative analysis published in 2019 by CESTAC. To summarize this prospective study, the results showed, without compromising outcome, there was accurate identification of EP-Clin low-risk patients who may safely avoid chemotherapy, regardless of menopausal status. And in those patients categorized as EP-Clin high risk, there was significant benefit from chemotherapy. A second evaluation of patient outcomes in a clinical setting is available from the Charité University Hospital in Berlin. To generate prospective real-world evidence from routine EndoPredict testing, Charité surveyed patient outcomes from those tested with EndoPredict between 2011 and 2016. The evaluation included 842 patients with HR positive, HER2 negative breast cancer and 0 to 3 positive lymph nodes. The key patient characteristics are as shown on slide. If we look at the patients according to the EP-Clin risk status, almost half were classified as low risk. In line with their result, most low-risk patients selected to receive endocrine therapy only. For these 392 patients, there was a very low 5-year distant recurrence of only 1.6%. In an exploratory subgroup analysis by nodal status, risk of 5-year distant recurrence without chemotherapy remained low in both groups, with 1.3% recurrence for node negative and 2.4% for node positive. Investigators concluded that patients with EP-Clin low risk scores, even without chemotherapy, had a very low risk of 5-year distant recurrence, independent from their nodal status. And analysing the high-risk patients according to chemotherapy use, 81.6% of patients classified as EP-Clin high risk selected to receive adjuvant chemotherapy. This graph shows the probability of distant recurrence-free survival for EP-clin high-risk patients based on their choice of therapy, with a 5-year distant recurrence of 3.6% for those receiving chemo versus 6.8% recurrence for those who did not receive chemotherapy. Concluding that patients with high EP-clin risk may have a worse prognosis without chemotherapy, but they may also benefit the most from chemotherapy. To summarise the real-world data from Charité, EP-clin was a significant predictor for distant recurrence in the absence of chemotherapy treatment. Patients with EP-clin low-risk scores had a low risk of recurrence independent of their nodal status, and patients with EP-clin high-risk scores may benefit the most from chemotherapy. Again, confirming the results seen in the multiple prospective retrospective validation studies for EndoPredict. With varying evidence across the gene expression tests for use of chemotherapy in the younger premenopausal breast cancer patients, I would like to take you through the strong evidence for EndoPredict in this patient group. EndoPredict is validated in both pre- and postmenopausal women. However, the majority of data available is for postmenopausal. To further confirm utility in younger patients, this study specifically evaluated the performance of EndoPredict in premenopausal women. 385 women with ER-positive, HER2-negative breast cancer, both node-negative and node-positive, were included. Samples were collected from unselected patient cohorts who were premenopausal at the time of diagnosis and systemically treated with adjuvant endocrine therapy alone. The primary objective asked is EP-clin risk score prognostic of 10-year distant recurrence in a premenopausal population? Key patient characteristics are as shown on slide, and the median follow-up is 9.7 years. And to answer the primary objective, is EndoPredict prognostic of 10-year distant recurrence in premenopausal women? 65% of the total study patient population were classified as EP-clin low, and as shown in green on the graph, had a low 10-year distant recurrence of 3%, significantly lower than those classified as EP-clin high, with a 10-year distant recurrence of 24%. Thus, with a median follow-up time of 9.7 years, EndoPredict is shown to be prognostic of 10-year distant recurrence in premenopausal women who received adjuvant endocrine therapy alone. Further analysis evaluated outcome in the node-negative and node-positive subsets. The evaluation showed the EP-clin risk score was strongly associated with 10-year distant recurrence-free survival, regardless of nodal status, as shown here, with 3% and 0% recurrence in the node-negative and node-positive subsets, respectively. Thus concluding that EndoPredict identifies premenopausal women with low-risk breast cancer who may safely forgo adjuvant chemotherapy, independent from their nodal status. To determine if the EP-clin score was prognostic independent of other clinical factors, a multivariate model was used. As shown in the table, EP-clin score was the only factor significantly associated with a risk of distant recurrence within 10 years of diagnosis, independent of age at diagnosis, tumour grade, Ki-67, and hormone receptor expression. Finally, I would like to summarise the position of EndoPredict in the guidelines. The test is supported by all the key guidelines, including ASCO, NCCN, St. Gallen, and ESMO, in both node-negative and node-positive patients, and importantly, in Europe, irrespective of menopausal status. It is also worthy of note that the chemopredictive studies for EndoPredict are acknowledged within the ASCO guideline publication. On a more local level, we can see that EndoPredict is equally supported by national guidelines, including AGO and NICE. So to summarise the key information I've shared with you today, EndoPredict is a second-generation gene expression test trained and validated in over 5,000 pre- and postmenopausal women. By combining the key clinical features, tumour size and nodal status with gene expression, a more specific prognosis can be established for each individual patient. New prospective data confirms the wealth of data seen in the validation studies, with reassurance of consistent results regardless of nodal or menopausal status. And finally, with a simple binary classification giving you a high, low-risk result, Regardless of patient group, the result is easy to interpret and explain. Add to this the ease of testing in a local laboratory in Greece, offering flexibility and speed to ensure you have the results available quickly to aid the discussion and decision-making with your patient. Thank you for your time today, enabling me to present the latest key data for EndoPredict. I hope the content has been of interest and that EndoPredict can support you and your patients in the management of their breast cancer. Thank you.